Dober dan in prav lepo pozdravljeni. Zdravstvo se nenehno razvija in sooča z novimi izzivi. Eden najpomembnejših dogodkov v zadnjih letih je seveda vse večji pomen digitalnih tehnologij pri izboljšanju obravnave bolnikov in doseganja boljših rezultatov. Digitalizacija zdravstvenega sistema ponuja številne prednosti, vključno z večjo učinkovitostjo, prihranki stroškov in izboljšanjem dostopa do oskrbe. Vendar pa digitalni prehod predstavlja tudi izzive in zahteva skrbno pripravo, načrtovanje in premislek. Pomembno je zagotoviti, da so koristi digitalizacije pravično porazdeljene in da se obravnavajo vprašanja glede zasebnosti in varnosti podatkov. Namen te konference je predstavitev strategije digitalizacije slovenskega zdravstva 2022 do 2027, ki je bila prav danes tudi objavljena na spletni strani ministrstva in seznanitev vseh ključnih deležnikov s prihodnostjo na področju digitalizacije zdravstva. Hvala, ker ste se nam pridružili tako v živo, kakor tudi preko spleta. Na oder pa sedaj vabim ministra za zdravje, da otvori današnjo konferenco in tudi pozdravi vse goste in sodelujoče. Gospod Danijel Bešič-Loredan, dobrodošli.
Lep pozdrav, spoštovane gospe, spoštovani gospodje. V posebno čast mi je otvoriti tako veliko in pomembno konferenco s tako velikim številom udeležencev. Namreč digitalizacija zdravstva, e-zdravje in e-karton so izzivi, ki nas čakajo od danes naprej svetlobno hitrostjo. So države, ki imajo to implementirano, in smo države, ki moramo to zadevo še implementirati. Preden naslovim nekaj misli, mi seveda dovolite, da najprej uvodoma pozdravim gospo Evropsko komisarko za kohezijo in reforme, gospo Elizo Ferreira. Danes je ni z nami, se je opravičila in nas bo nagovorila preko videa. Posebej mi je v zadovoljstvo, da lahko med nami pozdravim predstavnice Evropske komisije. Z Evropsko komisijo smo v zadnjih mesecih intenzivno sodelovali. Slovenija je namreč preko EU finančnih mehanizmov, to je programa za podporo strukturnim reformam oziroma inštrumenta za tehnično podporo, pripravila strategijo na področju digitalizacije zdravstvenega varstva, ki jo bomo danes seveda podrobneje predstavili. Z nami so tudi predstavniki Organizacije za ekonomsko sodelovanje in razvoj, OECD, kratica, to nekoliko bolje poznamo. Zahvala gre tudi vsem udeležencem in predstavnikom iz Portugalske, Španije in Estonije, ki bodo z nami aktivno delili njihove izkušnje. Prav posebej pa pozdravim kolegico Emilijo, našo bodočo ali pa aktivno ministrico za digitalizacijo. Veliko naj jo čaka še skupaj. V prihodu je tudi finančni minister, ki je seveda nad nama, zato ga bova še posebej pozdravila, ko pride. No, malo za hec, malo za res. Skratka, digitalizacija je izziv vseh nas. Zakaj? Digitalizacija pomeni transparentnost. Če smo transparentni, bomo ves denar, ki ga zberemo za zdravje ali za zdravje porabili, ali bomo pa videli, zakaj ga nismo za zdravje porabili. In ključ digitalizacije je v tem, da bodo vsi procesi jasno vidni vsem, jasno, z ustreznimi omejitvami dostopni vsem. Pa če se vrnem na pacienta in na tisto, kar je za nas važno, ali pa za slehernega prebivalca Slovenije ali pa Evropske unije. Pred nami je dokument, ki je plod solidarnosti Evropske unije. Je plod solidarnosti tega, da nam je mar, kaj se dogaja v naši okolici. Tako nam more biti tudi mar, kako bomo iz obstoječega nepovezanega zdravstvenega sistema prišli do tega, da bo sleherni od nas z digitalno osebno izkaznico prišel do zdravnika v katerikoli zdravstveni ustanovi in bodo na tej digitalni kartici vsi podatki, ki jih moramo vedeti mi, ki jih mora vedeti zdravstveno osebje in ki jih morajo vedeti drugi deležniki, s katerimi imamo opravka v družbi. Ključno je tudi to, da bomo s podatki, ki so na naši digitalni osebni izkaznici, upravljali mi. Ti podatki so naši. Ali bomo podatke o naši višini, teži lahko skrili, je naša stvar. Eni jih dovolijo, eni jih ne. Ključno pa je, in to imejmo vedno v mislih, zakaj je digitalizacija potrebna. Predstavljajte si, da se vam nekaj zgodi, po vas pride rešilec, imajo sistem, vtipkajo podatke in že na poti takoj vidijo vašo krvno grupo, že takoj vidijo, ali imate kako tveganje za krvavitev in že na poti v bolnico vidijo vaše ključne zdravstvene podatke, da vas lahko pravočasno oskrbijo. Videti jih mora seveda zdravstveno osebje, videti jih morajo vsi, ki bodo v našem procesu zdravljenja sodelovali. In če gremo še en korak naprej. Danes se Slovenija sooča z izjemno različnimi bazami podatkov. In če so vhodni podatki napačni, so izhodni podatki še toliko bolj napačni. Če vhodni podatki ne štimajo, niso in real time, kot temu rečemo, tudi priprava strategije, tudi oblikovanje kadrov, tudi oblikovanje potreb prebivalstva ne more biti točno. In zato potrebujemo digitalizacijo našega zdravstvenega sistema, vsega, kar se v zdravstvenem sistemu dogaja, in tudi na osnovi tega dokumenta danes bo vlada pripravila v najkrajšem možnem času zakon o digitalizaciji zdravstva, novo obliko e-zdravja, ki bo jasna, ki bo transparentna in ki jo bomo lahko mi vsi tukaj, predvsem pa pacienti, uporabljali nam v prid. Digitalizacija je orodje, ki nam življenje olajša. Ni orodje, ki bo spremenilo poteke zdravljenja, ni orodje, ki bo spremenilo način delovanja zdravstvenega sistema. Je pa ključno, pravzaprav orodje ali pa ključen proces, če temu rečemo, da pridemo končno tudi pri nas do modernega zdravstvenega sistema. Pri tem imamo podporo Evropske unije in končno, bom rekel, zgodovinsko priložnost, da zdravstveno reformo tudi izpeljemo. To je obveza te vlade, ta dokument je temelj, drugi dokumenti bodo še sledili. Hvala vsem, da ste tukaj, hvala vsem, da boste budno spremljali. Vsem skupaj želim eno izjemno predstavo, en vpogled v to, kar nekje že dobro funkcionira, in en vpogled v našo bližnjo in daljno prihodnost, brez katere pravzaprav ni možno imeti dobrega, kvalitetnega in modernega zdravstvenega sistema, ki je po meri pacienta. Hvala lepa.
Najlepša hvala za tale uvodni pozdrav in spodbudne besede. Sedaj pa si bomo ogledali drugi uvodni nagovor Elise Ferreira, in sicer komisarke za kohezijo in reforme. In seveda za prisotne v dvorani, vkolikor želite, lahko si vklopite tudi kanale za prevod pod številko 1 slovenščina, pod številka 2 angleščina in seveda tudi za tiste, ki nas spremljate preko spleta, možnost interpretacije. Torej, prisluhnimo Elisi Ferreira.
Dear conference participants, I recently read that there are 70,000 health-related searches on Google every minute. This represents 7% of all Google searches. This fact illustrates the two key drivers of today's conference. First, that health is a key concern for citizens. This requires the provision of access to health services to everyone, wherever they live, to fight territorial disparities in access to medical services. But second, that modern healthcare requires digital solutions. And indeed, digital solutions have the potential to introduce a revolution in healthcare. Telemedicine, bringing the doctor closer to, for instance, rural patients and to those with reduced mobility. Remote monitoring, an essential safety net, which enables patients to safely continue their daily lives. Electronic health records, so that doctors and nurses have instant access to all relevant information and treatment can be tailored to each individual patient. And public health data, the early warning system, which proved vital during COVID. Through all these ways, and this is just a couple of examples, digitalization is already revolutionizing healthcare across Europe. In fact, a quarter of the health reforms supported by the European Commission through the technical support instrument that you know, concern the digitalization of healthcare. And Slovenia's Recovery and Resilience Plan devotes 21% of its total allocation exactly to measures that support the digital transition, including digital infrastructure in the health sector and in the emergency health services as well. But digitalization brings challenges. Setting up systems requires expertise, requires capacity. And among healthcare workers and patients, digital skills are very uneven. So systems must be user-friendly and personnel must be trained. This is why more than 40 Slovenian stakeholders came together, representing the insurers, the hospitals, the primary care community centers, the Public Health Institute, the medical chamber, the patients, and they came together using resources and expertise provided by exactly the European Technical Support Instrument. And together, the partners designed what they called e-health system, which puts the patient at the center. Together, the partners draft a strategy for secondary data that will support innovation in line with European health data space. Together, the partners recommended a new support framework for IT infrastructure, a new financing model, and a revised coherent legislative package. This work was carried out in close cooperation with the e-health reformers in Finland, in Estonia, in Austria, in Spain, and in Portugal, which demonstrates the benefit of working together and of exchanging experiences. And the work continues today. You are living up to the Slovenian proverb, strike while the iron is hot. And indeed, this is the moment to work together, to provide modern digital healthcare for Slovenians and to act as an example across Europe. I am very proud that with the European Technical Support Instrument, we are able to help you design this important reform, and that with European funds, we are also supporting you implementing it. I wish you a fruitful discussion at this conference. Thank you very much.
Hvala lepa in mislim, da je ta dobra karizma dala tudi odlično iztočnico za to, kar sledi sedaj, in sicer prvi sklop današnje konference z naslovom Digitalna preobrazba zdravja, perspektive EU in OECD. V svojih vrstah imamo danes spoštovane goste iz Evropske komisije, Generalnega direktorata za podporo strukturnim reformam, DG Reform, in Generalnega direktorata za zdravje in varnost hrane, DG Sante, ter iz Organizacije za ekonomsko sodelovanje in razvoj OECD, ki bodo predstavili, kakšno tehnično podporo nudi Evropska komisija digitalni transformaciji znotraj EU, kaj lahko pričakujemo od nove uredbe EU zdravstvenih podatkovnih prostorov, EU Health Data Spaces, in seveda OECD-ov vidik digitalnih integriranih zdravstvenih ekosistemov. Z nami je prva govorka drugega sklopa, to je gospa Natalie Berger, direktorica Direktorata za podporo strukturnim reformam na temo tehnična podpora za digitalno transformacijo evropskih zdravstvenih sistemov. Mrs. Berger, welcome to the stage. The floor is yours.
Thank you very much. Dobry den, good morning. Dear Minister, digital transformation is one of the priorities of this Commission and an important vehicle to create the European Health Union and health data space, which will strengthen the European Health Union. Contributing to the digitalization of healthcare, DG Reform offers technical support for structural reforms to member states that is demand-based, voluntary, and tailor-made, of course. 1/4 of the currently running health reforms are linked to digitalization of healthcare systems. The high pressure on the healthcare system in the past health crisis has been an outstanding driver of change to, for example, rethink the governance of the e-health systems, solve interoperability issues, and develop national strategies in Belgium, Bulgaria, Croatia, Czechia, Estonia, Slovakia, and Spain as well. To respond to the major health crisis, the European Commission has released the largest stimulus package ever to help rebuild a post-COVID-19 Europe and support a greener, more digital and more resilient Europe of the future. The European Union's long-term budget, coupled with Next Generation EU, the temporary instrument designed to boost the recovery, is the largest stimulus package ever financed in Europe, with a total of more than 2 trillion euros in current prices. Reforms and investments targeting the digital transformation of health and care systems appear prominently in the national recovery and resilience plans. Reforms touch upon the digitalization of services throughout the different layers of health and care provisions. Investments are directed to the modernization of digital health infrastructure, of health facilities, and the training of the health workforce. An excellent example of a visionary landmarking project is your project on e-health for a healthier society. This project is linked to the implementation of key reforms in the Slovenian Recovery and Resilience Plan, and it will be backed up by more than 200 million euros of investments. Against the background of significant investment foreseen in digital infrastructures and equipment for the health systems, we presented for 2022 what we call a flagship project, a pre-designed, engineered project to the member states on digital skills for the health workforce. Concretely, with this initiative, we offer to help the ministries, and here we are going to concretely support the ministries of health in Estonia, Italy, Lithuania, Romania, and Spain to design and implement national roadmaps for digital skills for the health workforce and to strengthen the digital health literacy of the health workforce. And to conclude on the general topic of the part of the skills, our President of the European Commission, Mrs. Ursula von der Leyen, made the year 2023 the European Year of Skills. And we're delighted to see that digital transformation is also one of the key priorities of the Slovenian government. And Slovenia is a front runner with well-developed digital technologies and business models across sectors, a vibrant startup community, and one of Europe's supercomputers. However, even for a very advanced member state, faster, user-friendly digital transformation of health is needed, is very much needed, and a workforce that is skilled and able to keep up with the innovations will be the best investment to make in this country. At DG Reform, we are honored and proud to have supported our technical support instrument project on e-health for a healthier society that created a common citizen-centered vision for the Slovenian e-health ecosystem. Slovenian experts learned from the best practice exchanges from Austria, Catalonia, Estonia, Finland, and Portugal that supported and contributed to the work through the TAIEX instrument. As a result, the citizens of Slovenia will benefit from having a secure access to the health data, also across borders. They will be empowered to use digital tools to look after their health, stimulate prevention, and enable feedback and interaction with the healthcare providers. And I would like finally to emphasize the importance of the legacy of the Slovenian presidency of the Council of the European Union and highlight the major role that Slovenia has played in the light of the Commission priorities on advancing the health union and increasing the resilience of the European health systems. The Council of Ministers conclusions of December 2021 and the resolution of the European Parliament on cohesion policy as an instrument to reduce healthcare disparities invited the Commission to explore the provision of an advisory service with a single point of access to assist member states in making a better use of European funds. As a result, we designed a project together with Slovenia, Austria, Belgium, and with the assistance of Expertise France, namely the Resources Hub for Sustainable Investments in Health, which is one of the most important work streams that we kickstarted this year. This Health Hub will enable member states and project promoters in the member states to navigate through the various EU programs and funding instruments in order to identify how they could best use EU support. It will also provide networking, knowledge sharing, and guidance to build the capacity of the public authorities for reform design and implementation, and project promoters for the planning, the development and the implementation of large-scale health system transformation projects. In order to test solutions which will be developed as part of the project, each member state selected a pilot project. Slovenia identified digitalization in primary care. Austria decided to work on the greening of the Austrian healthcare system and the contribution to climate change mitigation. And Belgium will focus its pilot on developing integrated care, including digitalization, mental health care, and prevention. I would like, Minister, if you allow me, to congratulate you on behalf of the Commission, to thank you for launching such an important reform in the area of health, to thank you also for your trust in our technical support that deeply honors us. So thank you for the steps taken so far. And as our Commissioner previously stated it, this is the moment to work together to provide modern digital healthcare for the Slovenians and to act as a visionary, as a leader, as an example across the whole of the European Union. Thank you so much.
Thank you very much. Torej, kaj pa pričakovati od uredbe Evropske unije o Evropskem zdravstvenem podatkovnem prostoru? Licinio Custramano, zunanji svetovalec za e-zdravje, nam bo predstavil prav to. Prihaja iz Generalnega direktorata za zdravje in varnost hrane iz Evropske komisije. Torej, gospod Licinio Custramano se nam bo priključil online preko povezave. Bomo ga vsak čas. Yes, hello, welcome.
Good morning.
Yes, the floor is yours.
Thank you very much. Thank you very much. Good morning, Slovenia. Thank you very much for having us and giving us the opportunity to raise awareness and share with you the excitement about the regulation proposal on an European health data space, a space to support the European Union to harness the power of health data for people, patients, and innovation. Let's see what is all about this proposal. So, in 2020, the European Union presented the strategy for data. This strategy is based on plans for European common data spaces. We will see the data spaces in the coming slides, but the idea is to generate potential for big blocks of data and to take out insights that can help us. In that strategy, the European health data space plays a specific role that you see, and this is the focus of the regulation. The COVID pandemic also demonstrated the importance of digital services in the health domain, how it helped us to overcome some of the challenges, and triggered an acceleration in the uptake of digital tools, as well as set the European Union as a global leader and standard setter, like, for example, in the digital COVID certificate for vaccines. So today, the challenge is to maintain this momentum and to take it one step further and to build an European health data space that is useful and that is vibrant. How to do that? First, the challenges need to be clear. So today, individuals have difficulty accessing and controlling their health data, meaning that they may not be in the possession of all the tools, all the skills in order to, and also access to the data so that they can take the best of it. Health professionals, in turn, have difficulties accessing health data beyond their organization, and this makes difficult the continuity of care. Policymakers may also have difficulties in accessing health data in a way that they can make evidence-based, real-world-based decisions. In the other hand, the producers of health products face some barriers while trying to put their products in other countries, to sell their products in other countries. And researchers, they need access to data in large quantities to be representative of the population, and they face limitations in doing that at cross-border, at European scale. So in order to overcome these problems, the European Health Data Space Regulation was presented in 3rd of May last year, and it focused around these three building blocks: empowering individuals to access and control their personal data, unleashing the data economy by fostering a genuine single market for digital products and services, and ensuring a consistent framework for the use of individuals' health data for research, innovation, policymaking, and regulatory activities. In one single slide, you can see what this regulation is all about. Its objective is the effective use of health data, and it's organized in two dimensions. Let's use the dimension primary to identify the use of health data for primary purposes. So primary is equal to healthcare purposes. And here we will see objectives like empower individuals, standardization and mandatory certification of electronic health record systems, voluntary labeling of wellness apps, and a common format for European electronic health records. On the secondary use is all about research, innovation, policy making, regulation. So we call this the reuse of health data. We call secondary use in one word. So it creates the concepts of health data access bodies, purposes for use and forbidden use, and it introduces the mechanisms like data permits, secure environments, and no possibility to identify individuals while doing research, innovation, and so on. The means to achieve this is this proposal introduces legal and governance obligations, quality of data mechanisms, infrastructures that we will see two of them, and it works a lot on capacity building and digitalization exercise. So this proposal is connected with other European legal initiatives. It builds upon the GDPR. It aims to beat the cancer plan by providing more tools for researchers. It makes tailor-made rules for the health sector on top of the Data Act and Data Governance Act that are horizontal acts. It complements the cybersecurity framework specifically for electronic health record systems. It supports the Artificial Intelligence Act by contributing with data and defining quality of data for that purposes, and also integrates the medical devices regulation in order to ensure interoperability between the data produced and the data to be further used in electronic health record systems. But the European health data space is not a single space. As at the beginning we mentioned, it's a common of spaces. And we can see here, it's a complex, busy slide, but the idea is to show that there are many spaces, and the fundamental idea are the following. There will be things that you can share. You can share a technical infrastructure for data spaces, edge infrastructure and services, cloud infrastructure, high performance, AI, and AI testing and experimentation facilities. So these are technical infrastructure that could be shared. But the potential also comes for combining data from different spaces. For example, health with agriculture, health with environment. The insights researchers can achieve from being able to do that are remarkable, and that's not possible today. So we hope the European health data space and the data space in general can help scientists and policymakers to do those goals. One concrete example on how the European health data space will foster and give one step forward regarding the provision of healthcare is the My Health at EU infrastructure. This infrastructure enables that citizens from our countries to travel to another European member state, and if in the need of healthcare, for example, if it goes to an emergency in a hospital, if it goes to a pharmacy, this infrastructure enables the obtainance of the patient summary. It's a summary of your health conditions, your past, or the prescriptions, the medicine prescriptions you got in your home country, they are available in the country where you are. As of today, My Health at EU is already available in 11 member states, the dark blues in the picture. But as you can see, a lot is happening between 2023 and 2025, where the plans are for almost member states join the network. This means no citizens treated differently. So everyone has access to these services. That's the ambition. Following the example of the My Health at EU, the proposal launches the idea for a new infrastructure, the Health Data at EU. And this infrastructure follows the same principles. Data stays where it is, so data stays in the respective country, but it creates the channel to enable the reuse of health data at cross-border level. So we can imagine the following. A researcher in Slovenia is trying to get data for pancreatic cancer research. And it looks in Slovenia, it looks for data and it found a registry in Slovenia. But with this infrastructure, that same researcher will be empowered to find pancreatic cancer registries all over in the other European member states. And it will, in one single application, apply to have access to that source of data. And with access to that source of data, it can enrich the research so that it can be more representative, more patient, and that will hopefully bring us more insight and will help us save life, or at least increase the number of breakthroughs in science. So this is the proposal for Health Data at EU, a new cross-border infrastructure to support the reuse of health data. Now, coming closer to the end of my slide, which are the expected benefits for healthcare, for the primary use? So empower people to have better control over their own health data and to easily share with health professionals. You remember the idea of this common European health record format. So a format that says patient summaries, e-prescriptions, and in the future, laboratory results, images results, hospital discharge letters. They follow a common format that allows this data to be transferred and translated without losing meaning across the borders. So this leads to increased data sharing, better health outcomes, and if we foresee savings for patients and insurers by reducing unnecessary tests. It also enables health professionals a better access to health data inside the country, but also at cross-border, as we saw through My Health at EU. This possibly will enable better diagnosis and treatment, improved patient safety, and continuity of care. And if possible, let's see less manual data input that burdens a lot health professionals. At EUI, standards for electronic health record systems will make easier the life for manufacturers to sell their products in different member states, and this will increase competition and quality of solutions. On secondary use, when we speak about innovation, policy making, regulation, the expected benefits are to assist the policymakers and regulators in accessing relevant health data. As it mentioned, this will create the possibility for decision based on real world evidence. And this will lead us, this is our expectation, to more resilient health systems. It will facilitate access to health data for innovators in industry. So this means that there will be greater opportunities for research and innovation, and increase the number of breakthroughs leading to innovative medical products. In the same line, make available health data for researchers. And this will, we hope again, and this is what our impact assessment shows, that this increases opportunities for research and innovation. So this is what the European health data space proposal is all about. But this proposal is now being negotiated at the Council and Parliament level, and the proposal may change in its form. The ambition is the same, but the form may change. What we need is Slovenia and Slovenia stakeholders to follow closely and to understand the ambition so that they can translate to the ground, to the field, and participate in the initiatives that are being launched, funding initiatives to build these infrastructures from ground up and make sure that no country stays behind, no patient is forbidden of access to these services because my country is not engaged in this European infrastructure. Thank you. Thank you for having us. It was a pleasure to share with you the ambition and excitement for the European health data space.
Thank you very much. Hvala lepa za to odlično predstavitev. Sedaj pa od zdravstvenega evropskega podatkovnega prostora na pot k integriranim ekosistemom e-zdravja. Slednjega nam bo predstavil Eric Sutherland, višji zdravstveni ekonomist na OECD. Eric Sutherland se nam bo tudi pridružil online. Mr. Sutherland, welcome to our conference. I hope we hear each other.
Absolutely, and
Yes.
thank you very much for inviting me here today. Thank you, ministers, thank you, conveners, thank you, delegates, for listening to where we are observing more of a global perspective around the evolution of digital health and integrated health information. My reflection upon seeing the last two presentations is that there is remarkable convergence of how the approaches to digital health and e-health are evolving globally. And I'm happy to share some of those insights with you guys today, very much plotting the work that Slovenia has been doing with the release of your e-health strategy today, as well as give you some perspectives from other countries of some of the challenges that they have faced in advancing their strategies, such that hopefully it may be useful for you in consideration as you're advancing your own work going forward. With that, I will now remember to share my screen. So from our perspective at the OECD today, I really want to talk about the perspective of health transformation and the importance of integrated health information really as a foundation of a lot of these various strategies that are moving forward, which obviously interrelates strongly with the work of the European health data space that we just heard about. Can then also talk about some of the barriers that others are facing in this space that may be useful for you to be aware of, and then ultimately advocating for continuing the good work that you are already starting on strengthening your foundations for this health transformation that is so necessary in today's day and age. When, from the OECD perspective, when we look around the world at where various health systems are evolving, there are lots of, for lack of a better term, buzzwords around things where people are trying to advance, say, learning health systems, where they're thinking about integrated healthcare, where they're advancing genomics or artificial intelligence, health equity, and all of these things are tremendously important and should be the outcomes of various initiatives in and of itself. Fundamentally, the movement is toward more resilient and person-centered health systems that are increasingly powered by analytics and driving toward evidence-based decisions. And when we do this, the good news from a health perspective is that we've observed these types of transformations about becoming more person-centered and more resilient already happen in many other industries. In the aeronautical industries, obviously, we have everything on our cell phones nowadays from a banking perspective. We can order groceries to our home in 3 clicks of various buttons. And from an education perspective, there's an increasing shift toward digital delivery of services in and of itself. And so from our perspective, from health and from a social services perspective, we can learn from a lot of their experiences in and of itself. And what we learn from that is that as these different industries have advanced their transformations, they've really built their transformations by re-envisioning what their technical infrastructure and what their data infrastructure are, and that these industries have really invested strongly in the practices of their digital infrastructures and their data governance practices. And so from a health perspective, we see that advancing any of these various strategies to become more resilient, person-centered, empowered by analytics requires a foundation of digital tools and of e-health writ large and of health data governance. And when the OECD actually came out in 2017 with a declaration around health data governance, and we've been assessing this periodically over the last many years. We issued a report last year, and Slovenia, as you can see, is positioned very well amongst peers in terms of its data governance capabilities and its abilities to integrate and use data. So as we've already heard this morning, Slovenia is an advanced player in the digital health space, and there are opportunities to advance some of the work that you already, as is very clear from the release of the strategy today, in order to take the next step to really strengthen your foundation and move forward meaningfully. And when you do, which again we just heard about from Mr. Mano, that there are great benefits in clinical practice for individuals being empowered in their own care, preventing and helping out our public health practices to both be prepared for future pandemics and to actually be more resilient in the face of those pandemics, and driving the research and innovation agenda as well from a perspective of trying to drive our economic outcomes. So much of the same reflections of what we've already heard. We see that what is happening in Slovenia, what is happening more broadly across Europe, is also happening more broadly across other global partners. As we reflect on some of the barriers that organizations are facing in advancing their digital strategies, and there are many countries that, as you can see with one of the reports that we did last year looking at electronic health records development, many countries are advancing their work in this space, and they're facing barriers, which can be legal capacity, worrying about your data quality, and then making sure that we have the appropriate resources in place in order to make the relevant change. What is important and interesting about a lot of these reflections around the challenges that countries are facing is that many of the barriers are actually non-technical. A lot of the technologies that are available today can do what we envision we want to be able to achieve, and the challenges that are facing many of the countries that are advancing this work are related to the people that are involved, the culture in which the country is operating, the processes and policies that are in place, and ensuring that the appropriate governance needs to be clear about who is accountable for implementing the program and who is actually, and following up on that accountability to make sure that there is follow through in that work. In looking at some of the specific strategies, specifically did a quick scan of the United Kingdom, Australia, New Zealand, and Canada with some recent work. There was clear convergence around certain pillars of their various strategies that they're doing to advance the work of digital health and improve their better use of health data for both the primary and secondary uses, as Mr. Mano talked about earlier on. And many of these strategies really center on improving the policy environment, making it more consistent across the country, improving the engagement with people, with providers, with the workforces, in order to make sure that they buy in to what change is happening. And as we also heard earlier on this morning, improving the transparency about what we're doing to measure how we're actually achieving what we want to achieve, and be transparent about how we're achieving it, and be transparent about what controls are in place, what barriers are being faced, such that there is appreciation for the efforts that are undertaken to protect the information of individuals while using it most effectively for the provision of care. Many countries are also facing barriers with respect to capacity. Again, we heard about that earlier on this morning. Interoperability is a key and pervasive challenge in terms of defining what are the standards and how to actually move data across the various data platforms and technology platforms that we have. And again, ensuring that there is governance in place to hold everyone to account, define the accountability, and then hold and measure the progress that we're making against in the program to actually achieve the overall outcomes we want. And in this slide, reflecting these 5 major pillars of activity, they actually line up nicely with the work that the OECD did several years ago on our health data governance principles. When, however, I look at the specifics of the Slovenia health strategy, not surprisingly, it very much lines up with one important addition and innovation, I would say, that Slovenia has done in your strategy, specifically in the addition of finance as one of the key pillars, because it's not just about the governance of the system, it's also in ensuring that we have the financial capability to actually move this work forward. In terms of the types of barriers in these respective areas that we've seen other countries face, from a legislation point of view, many other countries are shifting their legislations and their cultures from one of data ownership, where often individual providers or health organizations feel like they have ownership of the data that they have been provided, and thereby they control whether or not that data can be shared and used for other beneficial purposes. What we're seeing many of these countries do is embracing the concepts of health data stewardship, wherein it encourages the reuse of data for better primary care, ensuring that the providers have complete information about individuals, ensuring the individuals have their own data and can control their own data to a certain extent, as well as ensure that data are used with appropriate protections in place to improve the health system for research and for innovation. And a lot of those organizations and a lot of those countries, as they're doing that work going forward, they are looking at what a modernized version of health data legislation looks like from a privacy perspective, from an access perspective, from a control perspective, et cetera. And a lot of that is shifting away from the concepts of data ownership into the concepts of data custodianship, where organizations are holding custody of the data, and of data stewardship, where they're accountable for ensuring, again, the reuse of those data practices. From a services perspective, when we look at the engagement side of the coin and the services that are provided, and this is well covered and was covered earlier on, and also very nicely covered in the strategy, there are challenges with trust of various health systems for the public, of providers, and a lot of that can be improved by the work of transparency that we've already talked about this morning, improving data literacy, improving digital literacy, the ability of individuals to actually make meaningful use of the information that they're going to be provided because of the implementation of these work of the strategy in and of itself. And a big part of that also relates to having very strong and constant communication amongst all the people that are involved in this work. This is probably one of the areas where I've seen most countries spend a disproportionate amount of time early in the program to actually ensure that there is buy-in and understanding of the why these changes are being made, what outcomes can be achieved, and how progress is actually being made in this space. And that is actually built better partnerships and actually got more engagement and buy-in and support for the work in of itself, which has actually helped to accelerate the various programs in and of itself. Having said that, one of the other major challenges is in the workforce, and on top of these challenges that, again, we already heard around capacity making sure that we have the sufficient number of professionals and people who can actually implement the program, having sufficient people who can actually make use of the tools and technology once implemented that actually drive the benefits from the program in and of itself. There is also the challenges of culture where this is a significant change. And anytime that there is a significant change, again, other countries are noting that there can be resistance to that change. And so having those strong communications, getting the buy-in from people, involving the public, involving providers in the change in of itself, ensuring that the outcomes are things that people are seeking and actually will benefit from and are able to communicate the benefit that they've received is one of the things that can be done in order to shift the culture to actually driving the reuse of data as strongly as possible, as well as ensuring its protection. And actually taking one of the sentences that I saw from the recent work of the EU, ensuring that data are as open as possible and as protected as necessary is one of the things that I think from a cultural perspective would really help as this work moves forward. From an IT perspective, a big part of the challenge is that many of the technologies that are in place may have been in place for decades, for many, many years, and are hard to change. And thereby, when we're thinking about upgrading these technologies, it is very hard to change. And there's a lot of cost associated with changing those requirements. Further, when actually implementing new tools and technologies, we may accidentally implement new tools and technologies that are themselves hard to change. So one of the lessons that other countries have learned is to design the architecture to be much more fluid and flexible, and where it is more component-based, where it is easier to take components out of the system and replace them with new modern components. One of the reflections is that whatever tools and technologies we are using today will likely be different in 10 years. In the same way that I reflect that, for example, 20 years ago, very few of us would have had smartphones. And certainly 10 years ago, that proliferated where virtually everybody has a smartphone in their pocket. We don't know what the new tools and technology is going to be in 10 years, and designing our technologies and our architectures to be able to adapt to those new opportunities when they arise is going to be one of the key things that we'll do. And one of the important areas that I think may be interesting from an IT infrastructure perspective is to consider the opportunities that come from artificial intelligence, for example, because to scale those algorithms, and we heard a bit about this before, around the ability to scale within Slovenia and for Slovenian innovations to be able to scale more broadly across Europe, we want to be able to make sure that the infrastructure, the IT infrastructure, allows us to be able to scale those work, and that the policies and processes and technologies are in place that simplify that ability to scale within the country as well as across borders. And finally, from the governance and finance perspective, and this is where I heard in a conference earlier on this year, is where one of the areas where finance can uniquely be a lever in this space, and again, is why I very much applaud the inclusion of it as a pillar in the Slovenian strategy, is that the reflection is that many of our current tools and technologies, as they've been implemented over time, have resulted in largely fragmented tools and technologies and systems that aren't able to talk to each other. And in order to be able to create comprehensive records require significant investment that is increased cost and in itself hard to sustain in the long run. And so one of the opportunities that comes from the governance perspective and where finance can be used as a lever in this space is to actively encourage the reuse of existing tools and technologies and systems, data standards and policies wherever it is possible to do, and have that as a requirement of the financial approval of the various investments that we have going forward. We know that the costs of implementing these types of programs are increasing, and the costs of healthcare are increasing across all OECD member countries. And at the same time, the actual economies of those countries are not growing as rapidly as the cost of the health portfolio in of itself. And so we must have a way to actually bend the increasing cost curve of finance, of health finance going forward. And a big part of that comes from encouraging the reuse, especially from these digital tools and technologies going forward. And I think that Slovenia is well positioned to be able to do that with the work you've done in the strategy. And it's one of the areas where I'm hoping to take this, your innovation to other countries, that this is something that others can actually meaningfully learn from as they're doing their work going forward. So just wrapping up, just reflecting from the OECD perspective, a big part of what we do is help the scan of what is happening globally in this space across all of the 38 OECD member states. We issued a report around health data governance in the digital age last year, really reflecting that a strong foundation of health data governance and integrated health information systems is really essential for 21st century care. For the digital age, it requires the data to be meaningfully shared and accessible. One of the analogies I've used is that if digital tools are the pipes and data are the water that flow between those pipes, we want to make sure that we have a robust ecosystem of pipes and water to make sure that the right data are getting to the right people at the right time for the right purpose and the right outcome. And that can be from a primary perspective, and it could be from a secondary perspective with the appropriate water filtration systems in place to ensure the appropriate quality of that data and of itself to the right people at the right time. And so one of the things that I look forward to as we're advancing this work around the OECD is to gather and share the insights that leading countries like yourselves are doing to actually spread some of the innovations, as well as to accelerate our opportunities to work within borders and across borders within Europe and across other OECD countries going forward. The other things to reflect that we've actually done recently, we did a deep dive into 2 health systems, one in Korea, one in the Netherlands, to do a fulsome scan of their health systems with respect to their health information infrastructure, and provided some concrete advice for them around how they could actually advance those systems in and of themselves to actually adhere to the OECD guidance in a way that helps support what their long-term strategies are for their health systems in and of itself, as they're looking for similar programs around digital care and advancing digital health ecosystems. Because ultimately, when we do all this, the ultimate outcome, again, reflecting on many of what I've heard this morning, is having this integrated, person-centered health system that is powered by eHealth, and the information that is flowing seamlessly amongst various organizations will create systems that are more resilient, more person-centered, powered by analytics, built on a foundation of health and health data governance that requires harmonized policy, solid engagement with the public, the sufficient capacity to execute and realize its value, the standards in place to actually create the interoperability structures supported by strong governance to make sure that we're following through on the outcomes. And when we do all that, not only will we have a happier and healthier Slovenian society, we'll have a happier and healthier European society, and I would dare say a happier and healthier and a more well global society as well. And when we make these changes, we need to be worrying about the policy reforms, the public engagement, the capacity, interoperability, and governance. Can't say that enough. And with all that said, I hope that was useful and interesting for you. And I'm looking forward to listening to the rest of the discussions this morning.
Mr. Eric Sutherland, thank you very much for everything said and these useful insights. Hvala lepa torej gospodu Eriku Sutherlandu. Sedaj pa, ker se zavedamo, da je mreženje, povezovanje in tudi klepet ob kavi ključnega pomena, kakor tudi strokovna razprava, vas vabimo na osvežitev, odmor, kavo, čaj in ponovno se snidemo 10 in 15 minut v dvorani. Medtem pa predstavnike medijev poprošam, da nam sledijo v kristalno dvorano, kjer bomo imeli tiskovno konferenco, ki se prične ob 3:15. Torej, vidimo se po odmoru. Spoštovani, dobrodošli nazaj. Upam, da ste imeli prijetno osvežitev in tudi kakšen konstruktiven klepet. Sedaj pa nas čaka drugi del današnje konference in ponovno kar precej zanimive vsebine. V drugem delu se bomo posvetili digitalni preobrazbi zdravja in pogledali bomo slovensko perspektivo. V tem sklopu bomo predstavili rezultat sodelovanja Evropske komisije, ki je preko Generalnega direktorata za podporo strukturnim reformam, DigiReform, s pomočjo sodelovanja zunanjih strokovnjakov in slovenskih deležnikov na področju zdravstva v Sloveniji omogočila pripravo slovenske strategije digitalizacije zdravstva 2022 do 2027. Ministrstvo za zdravje, Direktorat za digitalizacijo v zdravstvu, bo predstavilo slovensko strategijo digitalizacije zdravstva. Nato bo predstavnik UKC Ljubljana predstavil sodelovanje pri projektnem čarterju omogočanje storitev znotraj implementacijskega načrta strategije. Na koncu pa seveda tudi Združenje zdravstvenih zavodov in Gospodarska zbornica Slovenije, ki bosta predstavila svoj vidik sodelovanja pri pripravi strategije. Na oder tako vabim gospo Alenko Kolar, vršilko dolžnosti generalnega direktorja Direktorata za digitalizacijo v zdravstvu, ki nam bo predstavila strategijo digitalizacije zdravstva 2022 do 2027, projekt TSI e-zdravje za bolj zdravo družbo. Spoštovana gospa Kolar, izvolite, oder je vaš.
Hvala za besedo. Lep pozdrav v mojem imenu. Jaz sem tista, ki je takrat bila kriva, da ste zapirali na potnice. Če me še ne poznate. Zdaj, minister je napovedal izredno zanimivo in sploh zabavno in odlično dogajanje danes. Jaz se bom trudila uresničiti njegove besede in predstaviti strategijo, kjer pa moram takoj dodati vsaj dva disclaimerja ali pa en disclaimer in eno zahvalo. Ta strategija se je začela delati avgusta leta 2021. In pri samem začetku in pri najhujšem delu, ko smo se Slovenci borili za denar, za načrt za okrevanje in odpornost in ko so se dogajale vsa srečanja z deležniki, mene ni bilo zraven. Jaz sem prišla zraven s 7.7. letos, tako da se v tem trenutku zahvaljujem vsem kolegom iz MZ-ja in povsod druge, ki so sodelovali pri tvorjenju te strategije in bomo kasneje malo pogledali, od kje vse so prihajali. Želela sem, ko sem razmišljala, kaj povedati, predvsem ne želim, da bi zvenelo izredno abstraktno in da bojo novinarji spet napisali na koncu, da je nekaj v zraku, pa itak ne vemo, kako bomo to naredili. Nikakor si ne želim, da greste iz tega srečanja s takim občutkom. Seveda pa ne želim tudi iti zelo v tehnične podrobnosti, ki bojo dolgočasne za vse, razen za tistega IT-ovca v Sloveniji, ki slučajno nekaj zelo veliko ve o tem. Tako da moramo nekje pluti na meji med obojim in se bom trudila to tudi narediti. Začela bom z eno izkušnjo, ki mi jo je predal šef EY Pantheon Slovenija, gospod Domen, ko je rekel, ko so zvedeli, da je Evropska komisija njim dala razpis, da so oni tisti, ki bojo za Slovenijo delali strategijo, je imel že preden se je zjutraj spod tuša stopil ne vem koliko neodgovorjenih telefonskih klicev in SMS-ov in vsi so bili bolj na temo tega, kako bi bilo treba to strategijo narediti in kaj je treba not napisati. To je bilo 40. že do 8. zjutraj, tisti dan, ko se je izvedel, kdo je za Slovenijo pričel pripravljati to strategijo. Tako da lahko že z tega vedete, da je bil zelo velik interes, predvsem z področja gospodarstva, kako naj bi ta strategija izgledala. In moram čestitati vsem, ki so sodelovali, da so se ognili čerem tega, da smo na nekoga strategijo napisali in da mislim, da ni upravičena kritika, da je kje kaj tazga zapisanega. Zdaj, kaj s tem projektom smo želeli in zakaj strategija? Tukaj je napisano, da smo zaostali v razvoju. Prej ste lahko videli na prosojnicah gospoda Sutherlanda, da nismo tako zelo zaostali v razvoju, mogoče kakšno stvar ne znamo tako PR-ovsko poriniti naprej, kot to znajo Estonci. Po drugi strani pa točno vemo od estonske delegacije, ki je bila pri nas, da se obračajo na naše ljudi in naše ljudi sprašujejo, kako se lahko recimo naredi podatkovni nivo v zdravstvu. Tako da nismo tako slabi, ne znamo se tako dobro prodati. Upam, da vsi imate vem na vaših telefonih naložen. To je tudi nekaj, kar je izredno pomemben. Ko so Estonci rekli, mi to imamo, smo lahko rekli, pa to imamo tudi mi, saj ni to nič posebnega. Imamo pa, kot ste videli na preostalih drsnicah gospoda Sutherlanda, še veliko room for improvement. In o tem govori tudi ta strategija, ki je zelo lepo predstavi na precej visokem nivoju. Ne bomo danes reševali in vam povedali, kako shranjujete slike od zobarjev. Tega danes ne bomo razlagali, ker tega v strategiji ni. Zdaj, zakaj tudi mislimo, da je zaostanek in zakaj smo hvaležni, da je DigiReform dal denar, ker Slovenci imamo poleg pregovora kuj železo, dokler je vroče, tudi pregovor, da nihče ni pridigar v lastni vasi. Zato je zelo fino, da nam s to strategijo prehajamo iz Evropske unije, s podporo Evropske unije in s tem, da so sodelovali res strokovnjaki, tudi tuji strokovnjaki, ko se je ta strategija delala. Kaj pomeni izboljšati zdravstvene storitve za pacienta kot eden od glavnih ciljev? Več podatkov, boljša oskrba pacienta, manjša obremenitev zdravstvenega kadra. Zato moramo zdravstvenemu kadru nenehno nalagati, kaj mora vse vpisovati, pa kaj še kodirati, pa kaj še zakodirati, ampak moramo z arhitekturo podatkov zagotoviti, da zdravnik vnese vašo diagnozo, v zadnji se pa zgodi vse, kar se mora za potrebe statistike, NIJZ-ja, ZPIZ-ov, ZZZS-ja in ne vem koga. Razvoj enotnega zdravstvenega kartona, ja, tle bom šla majčkeno v tehniko, ampak morali se bomo dogovoriti o standardih, na podlagi katerih bomo delali ta karton. Ne kaj se vsak spomne, pa kaj se mu zdi prav, da bi vnesel v karton, ampak po nekih mednarodnih standardih. Mi se ne moramo ta trenutek niti zmeniti, kako bomo laboratorijske izvide standardizirali. Zato bomo v enem organu, ki je ustanovljen na ministrstvu, ki mu rečemo IRSK, to prepustili RSK-ju za laboratorijsko medicino, zdaj ne vem, če se čisto tako imenuje, ampak mislim, da vsi vejo, na koga mislim, da se uveljavi standard LOINC. In potem ne bo več izgovorov, jaz imam tako, ti imaš nekaj drugega, to so naši podatki, ki jih je treba priznavati med laboratorijsko. Uporabili bomo OpenEHR standard, uporabili HL7 FIRE, ne moramo si več zamišljati tako, kot vsakmu od nas paše, to je bilo danes večkrat povedano, ne gre, da vsak dobi tisto, kar si je slučajno zamislil ali pa kar je njegov bratranec naprogramiral pred 15 leti. Tako kot včasih žal danes v slovenskem digitalnem zdravstvu stanje je. Vzporedno ali pa zdaj smo začeli pripravljati tudi zakon o digitalnem zdravstvu. Zdaj, kako točno ga bomo poimenovali, se bomo še dogovorili, ampak to mora biti nek dokončen cilj, da ga pripravimo, kjer bomo dali večje pravice pacientom, kjer bomo bolj poskrbeli za ranljivejše skupine. Vedeti moramo, da veliko ljudi še, kljub temu se nam zdi drugače, nima dostopa do računalnikov, ne zna delati z računalniki, tem ljudem je potrebno pomagati. O tem malo, kako se je strategija delala, tle povzemam po tistem, kar so me naučili sodelavci. Več kot 40 deležnikov je sodelovali, nekateri so navedeni s svojimi oznakami tukaj in drugi. Ogromno je bilo izvedeno intervjujev. Covid nas je naučil, da so intervjuje lahko preko video zvez in večina tega je bilo izvedeno čez video zveze. Strateške delavnice so se izvajale, sodelovali so tuji pionirji na področju e-zdravja in petkrat že omenjene države, s katerimi so sodelovali slovenski strokovnjaki. Ene so fizično obiskali, nekatere smo imeli tudi prav tako čez video storitev. Zdaj, cilj teh delavnic je tale vizija. Jaz jo lahko preberem, ampak mogoče si jo raje preberete sami, je tudi v angleščini. Ta vizija je rezultat nekega brainstorminga, mi je povedal kolega, ki je pri tem sodeloval, kjer so se vsi te ljudje, vsi teh prej iz teh 40 zavodov, podjetij, so skupaj nagruntali, odločili se, kaj je tisto, kar mora naša strategija zajemati. Standarde sem navedla, prenova procesov, to bo najtežji del, ki nima tako zelo veliko zveze z IT-jem, ampak to bo najhujši oreh digitalizacije v slovenskem zdravstvu. Podatke in infrastrukturo, tehnika, mislim, da danes v IT-ju ni nikakršen problem. Tehniko bomo že našli, tehniko se da kupiti, rešitve so, ideje so, ampak to, da bomo pa spremenili sebe, ta del bo pa nekaj hudega. Jaz sem si malo pisala, kaj naj zraven povem, da ne bo tako dolgočasen, kar je tu gor narisan, tako da imam še nekaj zgodb ob tem. Kaj bomo, danes že parkrat je minister omenil, ministrica omenila, transparentnost. Zdaj, transparentnost se nam strašno fino sliši, pa ne vem, če si jo vsi želijo. Naslednja stvar, ki jo mogoče niso tako velikrat omenjali in jo jaz nosim s sabo iz meroslovja, kjer sem začela in iz farmacije, je pa sledljivost. Da bomo točno vedeli, kaj, kdo, kdaj, kje. In samo na ta način bomo lahko to delali v dobro pacienta. In mislim, da je to cilj vseh nas, ki delamo v digitalnem zdravstvu, v dobro pacienta. Zdaj, kaj vse v resnici digitalizirati? Tisti, ki ste bolj IT freak, ste že probali, kaj je chat GPT. Jaz ne vem, če si želijo naši pacienti, da jim artificial intelligence, umetna inteligenca napiše izvid. Nekje bo treba nehati, pa bo ta izvid, če ste poskusili to, ta izvid bo tako dober, da ga bo zelo redko kdo na gruntu, da ga ni napisal zdravnik, ki ga je gledal. Tako da tukaj moramo biti zelo previdni, kaj prepustimo računalnikom in kaj ne. Ena od vprašanj, ki smo jo dobili tudi zdaj na tiskovni konferenci, je namensko in centralno upravljanje e-zdravja. Do zdaj temu ni bilo tako. Ja, centralni del e-zdravja, ker je bil na NIJZ-ju ali pa je na NIJZ-ju. Ampak kaj se je pa delalo po zavodih, je bilo pa več ali manj prepuščeno posameznim poslovnim, strokovnim direktorjem, kirurgom, finančnikom in vsem ostalim, za katere jaz trdim, da so delali v dobro, ampak na koncu ni šlo skupaj in še danes ne gre skupaj. Še danes imamo težave s podatki, ki jih pridobivamo iz zavodov, iz terena, če tako rečem, iz proizvodnje. In ta del moramo popraviti, ljudem moramo dati neka navodila, kaj naj delajo, kako naj delajo. Meni je res vseeno, a je zaslon v enem zavodu rožnat, pa v drugem moder. To je sploh nepomembno, ne rabimo imeti vsi iste aplikacije. Samo podatki, ki grejo v centralo, pa ki grejo v vaš e-karton, pa morajo priti na enak način, enako strukturirani in en drugmu, boh ne daj, da pa še teh ne bomo priznavali en drugmu. Da kar je zapisal jaz ne verjamem, pa bom še enkrat meril. Ta del pa ni več toliko zveze z IT-jem, kad imaš človekom in z organizacijo in s tem, da se zavedamo, da smo na skupni platformi. Podatkovno vodeno, moram reči, da mi je bilo posebno veselje, ko so začeli Estonci omenjati, kaj bi bilo treba, da smo lahko Slovenci rekli, pa mi to že imamo, se NIJZ to že dela. In so rekli, pridemo pogledati, kaj bo to narejeno do konca. Učinkovit in trajnosten način, to mislim, da je pa danes že nekaj, kar moramo dati na vsak slajd, ker moramo biti trajnosti, pa moramo reciklirati. Zdaj, ta strategija zajema ključne gradnike tega sistema, upravljanje governance. Mislim, da je bilo dosti povedan, kako tega do zdaj nismo imeli, da je spet gospod, kako se je že pisal, Sutherland, tako kot Kiefer, da je treba ta del popraviti, da ne smemo nekaj drobiti, da pa moramo uvajati stvari modularno. To bo najtrši oreh. Strategija sicer zelo lepo predvidi, kako je treba sfinancirati. Vemo, da denarja, predvsem za projekte v investicije, ni malo, zdajle sploh ne, ker imamo načrt za okrevanje in odpornost, da tudi proračun Slovenije je radodaren okrog investicij, da so radodarni ostali evropski skladi, ma zinvestirali bomo že. Za vsakih 100 evrov, ki jih vložimo letos v IT, bomo drug let dali 20 evrov za vzdrževanje. Teh 20 evrov moramo pa še najti. In to moramo najti trajnostno, pa ne mislim zeleno, ampak tako, da bomo res dubali to vsak let in se ne vsakič sporod borili, da bomo lahko plačali licence, da bomo lahko plačali vzdrževanje, da bomo lahko nadgradili strojno opremo. Ta del moramo narediti in mora biti zapisan v zakonu in se ga predvideva v zakon tudi zapisati. Delovna sila. Zdaj, če bo denar, bojo verjetno tudi ljudje. V zdravstvu je izredno zanimiv teren za delo tistih, ki radi delajo kaj novega, ki jih veselijo stvari v IT-ju, ki se bi radi preizkušali, nove IT tehnike in ne konec koncev tudi zdravnik bo morda na podlagi podatkov lahko preizkušal nove zdravstvene tehnike. Ampak delovna sila, če zdaj govorimo striktno o IT-ju, je kritična. Nije, če lahko tako povem. IT-jevci s srednjo šolo v zdravstvu moramo jim doplačevati do minimalca. Zato, ker imajo srednjo šolo. Vi pa veste, da je lahko tak človek, ki ima par certifikatov v Googlu, hudo bogato plačan in zakaj ne bi šel raješ ven. Tako z ljudmi v IT-ju, v zdravstvu žal ne bo šlo več naprej. In tudi če bi jih plačali, jih ni neskončno mnogo. Potrebno bo združiti sile in porabiti sinergije učinkov, poenotiti stvari, da bo lažje vzdrževati vse skupaj. IT infrastruktura, mislim, da ta je še najmanj sporna, že zdaj obvladamo zelo lepo ZNet, potrebno bo zložiti stvari v neke skupne podatkovne centre, kjer bodo na varnem ti naši strežniki, ali pa preiti in začeti vsaj razmišljati, kaj če bi z nekaterimi stvarmi šli v oblake. Danes nekateri zagotavljajo, da so podatki kljub vsemu ostanejo v Evropski uniji in morda je treba zakon napisati tako, da so glavne knjige bolnišnic pa lahko v kakšnem oblaku, tam ni pa res nobenih posebnih osebnih podatkov. Razvoj obstoječih storitev, gradili bomo modularno, nikakor monolitno, ker to ne moremo več. To je prepočasi, preveč rigidno, danes beseda v IT-ju pa je agilno. Storitve naj dela tisti, ki jih najbolje obvlada, pa ne mislim zdravstveno, ampak da jo podpre tisti IT-jevsko podjetje, IT-jevski SP-jevec, ampak zagotoviti pa moramo, da bodo te aplikacije, ki se bodo povezovale, preizkušene varnostno, da bodo dajale podatke take, kot morajo in da ne bo moč čez njih vdreti v centralni sistem. Minister je že omenil, kibernetska varnost mora postati močno vsakominutno zavedanje v slovenskem zdravstvu. Ker hočemo vse to narediti in ker vse to not v strategiji je, strategija obsega nekaj čez 100 strani, sam osnovni dokument, tako da vam jo ga tle ne bom brala, je pa objavljen in si ga lahko, je potrebno v določenem delu spremeniti slovensko zakonodajo. Zdaj, to je ta znameniti trikotnik, je pravkar opisan, kadri, čas, finance. Če eden zmanjka, potem nimamo kakovosti, ki predstavlja površino tega trikotnika in tega si ne smemo več dovoliti. To je na hiter nekaj časovnih mejnikov, kako smo si zamislili in kaj nas načrt za okrevanje in odpornost na nek način sili, da pravočasno izvedemo, vzpostaviti novo centralno enoto za upravljanje zdravja, prenova CRPP, ki se že dogaja, prvih projekta pa sta centralni PAKS, vzpostavitev sistema in pa zbiranja, prenova CRPP pa sem rekla, da se že dogaja, transformacija CRPP v enotni zdravstveni karton ali kakorkoli ga bomo že poimenovali. In pa še eno stvar moramo, ki pa tukaj nismo narisali, moramo poskrbeti za zdravje nadaljavo, to je nek generično ime tega, kar razumemo pod telemedicino, nekako se mi lepše sliši, če se temu reče zdravje nadaljavo, ker v končni fazi menda nimamo prav dobrega prevoda za online pomoč pacientu in zdravje nadaljavo, to je tako kot coffee to go, zdaj je čisto v redu, če se reče, kako že rečemo, za na poti in podobne stvari, nadaljavo. Strategija bo prebivalce Slovenije. Še enkrat, transparentnost in sledljivost, boljša zdravstvena oskrba, če ve zdravnik hitro o vas, kar mora vedeti, ali pa če vas poberejo, boh ne daj po prometni nesreči, je fino, da ima podatke, s katerimi vam lahko pomagajo. Nove digitalne storitve, priložnost za gospodarstvo tako Slovenije kot širše Evrope. Če gremo v to, kar je predvideno, pa se mora tudi naše gospodarstvo zavedati, da prihaja konkurenca tudi od zunaj. In da seveda naše gospodarstvo lahko konkurira na zunanjih trgih. Lažji dostopi do podatkov, boljša uporabniška izkušnja, stvari, ki so nam tako zelo domače, ki pa bodo povzročili tudi nekatere neljube stvari in neljube spremembe. Mi si vedno vidimo digitalizacijo kot nekaj super, ampak digitalizacija je sprememba našega razmišljanja, je sprememba razmerij v družbi, druge vloge dobijo isti ljudje, drugače se poimenujejo stvari, nekateri, ki so bili do zdaj pomembni, morda ne bodo več tako pomembni in nekateri, ki so bili do zdaj underdogs, bodo postali pomembni. A smo pripravljeni pri vsem plusu, ki ga digitalizacija prinaša, sprejeti tudi to? Imam samo še 2 slajda, na koncu je hvala, ampak ta je predzadnji. Zdaj, ta druga točka, vključenost vseh deležencev, to je bila ena od bolečin, ki so jo izražali vsi tisti, ki so sodelovali pri postavitvi strategije. Vključujte nas, delajmo skupaj, poslušajte nas. Vsi, ki si želijo ali pa želimo sprememb jutri, če si hkrati želimo tudi, da smo vsi vključeni, vsak pove svoje mnenje, potem to jutri ne more biti. Ker če moramo se vsi strinjati, potem moramo si dati čas, da se dogovorimo. Ne samo, da se pogovarjamo, ampak da se dogovorimo. Zdaj, koriščenje evropskih sredstev, ja, novi fondi so na voljo, mi se moramo zmeniti, dogovoriti, odločiti, sprejeti konsens, da se ne bomo tepli na javnih razpisih. Mislim, da je Slovenija premejhna, da bi sploh lahko razmišljali, da kdo ne bo imel dela. Vsak bo moral delati, pa še to 2-krat delati, ker če ne bo nam uspel pobrati vsega tega denarja, ki nam je na voljo, če se bomo obtoževali po DKOM-u, da ena vejca manjka ali pa da je nek certifikat ni čista prav, ki ga zahteva naročnik. Tukaj potrebujemo pomoč gospodarstva, da se nam to zgodi. Zdaj, jaz bi rada zaključila z eno mislijo, pa nikoli mi ne rata biti tako zelo udarna za konec, ne. Ampak tukaj sem že rekla, digitalizacija spreminja razmerja. Spreminja razmerja med vlogami. Spreminja to, da se en register imenuje po enem profesorju, vsaj ne v zakonu, ampak vsi vemo, da je to pa od tega pa tega. Tega ne more več biti, če želimo imeti odprt zakon in ne bomo za vsak register not dajali vsakič, ko bomo našli nov register, bomo šli spreminjati zakon. Tega se ne moramo iti. Mi moramo generično pobrati zbirke v zdravstvu. In če se želimo to iti, se moramo posamezniki moramo pri sebi izvesti metamorfozo. Mi moramo postati metuljčki in ne dati nas kot gosence na bicikl. To ni digitalizacija. Jaz izredno in iskreno upam, da nam bo uspelo s sodelovanjem vseh. Hvala.
Najlepša hvala za tole mero agilne miselnosti in tudi sposobnosti znati reči Bobu Bob. Sedaj pa seveda od strategije nadaljujemo k projektnem čarterju. Omogočanje storitev znotraj implementacijskega načrta strategije. Z nami pa bo Blaž Suhač, vodja informacijske tehnologije na Univerzitetnem kliničnem centru Ljubljana. Blaž, lepo pozdravljeni.
Spoštovani minister za zdravje, spoštovani organizatorji in drugi iz ministrstva in pa seveda vsa ostala audienca. Jaz sem imel čast na povabilo ministrstva, da sem tako sodeloval pri pripravi strategije kot pri nekaterih projektih in danes bi povedal, kako smo prišli do nekih zaključkov na eni zelo konkretni nalogi, ki smo jo ves čas delali v angleščini in takrat smo govorili o enabling services in v resnici pred kratkim, ko sem pripravil to predstavitev v slovenščini, sem gotov, da nimam prevoda. Namreč, mogoče za začetek govoril bom o tem, seveda, zakaj to delamo, zakaj so enabling services potrebne, za koga, kaj in kako. Pa vendar za začetek ne prevedli smo v storitve, ki omogočajo, ampak to je dobesedni prevod in to ni to. Je pa v anglosaksonskem prostoru izraz enabling services v zdravstvu zelo dobro razumljen. Gre za vse neklinične, nezdravstvene storitve, ki so potrebne za to, da lahko izvajamo klinične in zdravstvene storitve. Se pravi, gre za logistiko, gre za transporte, gre za oskrbo, gre za prehrano, Torej, to niso stvari, ki jih neposredno potrebujejo pacienti. Pacienti potrebujejo zdravnika, sestro in diagnostiko in tako naprej. Ampak ti zdravniki in ti sestre in ti diagnostike pa v ozadju potrebujejo sistem, ki jih oskrbuje in podpira pri tem, da lahko oni kvalitetno delajo. Zato so enabling services izredno širok pojem, izredno pomemben pojem, zato da zdravstvo lahko deluje. Ker pa govorimo tukaj o digitalni strategiji, o digitalizaciji, smo se tudi pri tem projektu omejili na vlogo informacijske tehnologije v tem širši zgodbi enabling services. Skratka, ne bomo govorili o prehrani in oskrbi in transportih, ampak o vlogi IT-ja pri tem delu. Za koga, torej kdo potrebuje enabling services zdaj v tem ožjem pomenu besede? V prvi vrsti smo razmišljali seveda o vseh državljanih in državljankah naše države, ker so oni koristniki storitev javnega zdravstva. Vse v resnici delamo za njih. Drugi pomembni za nas so izvajalci v javnem zdravstvu, ker tako kot že sama definicija pove, oni so tisti, ki te enabling services potrebujejo. Mogoče druga alineja malo bolj organizacija kot taka, tretja alineja pa so dejansko posamezniki, zaposleni v zdravstvenih zavodih in drugih inštitucijah, ki, če smo pa zdaj že zelo konkretni, uporabljajo računalnik. Zadnja alineja je zelo pomembna, tudi tisti izvajalci, ponudniki IT sistemov, licenc, storitev. Danes že cel dopoldan poslušamo, poenotenje, standardi, javno, skupno. Če bomo želeli zares omogočiti vstop in sodelovanje različnih ponudnikov, je potrebno tudi njim pomagati z nekimi storitvami, da bodo njihove rešitve in končne storitve kompatibilne z to evropsko in nacionalno strategijo. Zdaj pa čisto konkretno, kaj smo počeli oziroma kako smo ta izziv razdelali. Na koncu se je izpadlo 5 točk, 3+2. Prve 3 točke so projekti, so nekaj, kar moramo narediti na začetku, ker kar se tiče teh storitev v digitalnem svetu na nacionalnem nivoju izhajamo iz nič. Treba je nekaj zgraditi in projekt je tisto, ki uvede spremembo. Štartaš iz nekje, tukaj nič, potem pa nekaj imaš in to potem predaš v uporabo in potem to živi in si dosegel svoje cilje. Implementacijski projekti so predvideni 3. Prvi je storitveno podporni kontaktni center, ker seveda v osnovi govorimo o neki podpori, govorimo o neki točki, kamor bodo lahko tiste skupine, ki so bile prej naštete, se obrnile za kakršnokoli obliko pomoči. V drugem projektu smo naslovili samo metodološko zasnovo, kako sploh izvajati IT storitve za tako veliko skupino deležnikov, za tako zelo različne deležnike. Ko govorimo o državljankah in državljanih, sem to lahko jaz, ki se imam za nekoga, ki mogoče zna malo opisati, kakšne vrste problem z računalnikom ima. Lahko je pa to moja stara mama, ki bolj potrebuje trenutno zdravstvo od mene, pa trenutno komaj komunicira, če smo čisto iskreni. Torej za vse njih mora biti ta sistem kompatibilen. Na drugi strani imamo pa seveda številne ponudnike IT sistemov, ki tudi sami imate svoje storitveno kontaktne centre in tudi sami to počnete in pravzaprav izredno dobro veste, kaj upravljanje IT storitev in podpora je. Torej, kako se dejansko tega lotiti in katera orodja, platforme, aplikacije bo ta kontaktni center potreboval, zato da bo lahko sploh svoje delo upravljal. Tretji izjemno pomemben projekt, mogoče celo najpomembnejši, pa centralizirati in poenotiti upravljanje baze znanja. Bolj tako na kavi ne bi jaz rekel, dajmo vam vsem pomagati, da ne odkrivamo tople vode. Nekdo je mogoče rešil en problem na nek način, pa drugi ponudniki to ne vedo, ker smo pač v takem okolju, je ta rešitev del nekega intelektualnega znanja enega posameznega podjetja in ga ne bo seveda želel širiti konkurenci, normalno, ne. Ampak za spremembo okolja pa lahko vplivamo na to, da znanje uporabe digitalnih sistemov in storitev postane nacionalno, tako kot so nacionalni tudi sami podatki o nas kot pacientih. Tem projektom bo seveda sledila predaja v uporabo, tako da za projekte lahko rečemo, da vemo, kdaj bodo začeti, pa kdaj bodo končani, medtem ko samo izvajanje v uporabi si pa seveda ne vidimo cilja, ne vidimo konca, dokler se okolje ne bo spremenilo, želimo to početi in takrat bodo te enabling services imeli dve nekako enoti, ki boste izvajali stvari. Prva je ta storitveno-kontaktni center, drugo pa je podpora pri zagotavljanju kvalitete storitev oziroma angleško spet boljša beseda je quality assurance. Kje je tukaj upravljanje baze znanja? V resnici v obeh, bolj mogoče v storitveno-kontaktnem centru, pa ker v projektih nisem to govoril o quality assurance, bom mogoče zdaj. Ponovno govorimo o nekih standardih, o nekih pravilih igre, ki jih želimo uvesti na nivoju Evrope, na nivoju države. Seveda na drugi strani pa smo odvisni od ponudnikov raznih aplikacij, raznih storitev, mislim pa ne samo odvisni, želimo biti z njimi skupaj, so odvisni, pa vendarle nekdo mora obstajati, ki bo pred predajo neke rešitve ali pa neke storitve v te centralne sisteme zdravja preprosto mogel preveriti, ali so skladne z pravili igre. O projektih ne bom kaj prav bolj v podrobnosti razglabljal, bolj mogoče tisti končni izdelki, a ne končni cilji, ki jih sledimo. Se pravi, kaj dejansko bo centralna vstopna kontaktna točka, kako se jo predstavljamo. Z njo želimo povezati državljane in državljanke, ki koristijo e-zdravstveno platformo. V praksi bi to pomenilo, da jaz kot državljan, kot mogoče potencialen pacient, lahko nekam pokličem in dobim sogovornika, ki mi bo pomagal, kako na zavemu se sploh najdem napotnico in se naročim. Spet nekateri to potrebujejo bolj kot drugi. Pomembno pa seveda je, da je tak kontaktni center za te stakeholderje razpoložljiv 24/7 in da je na drugi strani sogovornik, ki je zmožen bilo koga, torej ne glede na osnovno znanje digitalnih sistemov, sposoben tega človeka voditi, da izvede svoj, pač doseže svoj cilj. Potem so tukaj izvajalci razvoja in podpore, ki tudi morajo imeti možnost, da rečejo, ja veste, mi pa zdaj programiramo eno aplikacijo, s katero bi želeli, da se lahko en zdravnik preveri, ali je neka napotnica res pač registrirana, ali je pacient naročen, pa ne vemo, kako to v nacionalnem sistemu narediti. Ne znamo se avtenticirati, ne poznamo podatkovnih modelov, ne razumemo statusov in seveda ta kontaktni center bo preko dokumentacije ali pa tudi individualne podpore izvajalcu pomagal, da bo lahko svojo rešitev razvil. Potem so seveda tukaj naši zaposleni, ki spet uporabljajo te aplikacije, da bo lahko nekdo iz UKC Ljubljana ali pa tudi skje druge poklical pa rekel, ja veste, jaz pa vem iz nekih drugih virov, da se ta oseba je naročila. Jaz ga pa v moji aplikaciji ne vidim, a mi lahko pomagate, spet, da sem konkreten. In pa podpora nacionalnim organizacijam, kot so ZZZS, NIJZ, vse veste, katere so vse, ki so vključene v to regulativo, ki sodelujejo v interoperabilnosti in ki so pač del te večje nacionalne zgodbe zagotavljanja podatkov. Seveda kontaktni center ni samo zato, da dvigne telefon pa tako na hitro nekomu pomaga. Obstajajo problematike, ki so težje rešljive ali pa nerešljive takole na hitro. Torej oni bojo mogli biti most na drugi in tretji nivo podpore, torej most do ponudnikov različnih delov sistema in različnih storitev, kar pomeni, da bodo mogli znati prepoznati iz opisa kličočega ali pa pišočega, na koga vse se je potrebno obrniti, zato da bo ta problem po eni strani učinkovito, po drugi pa tudi zares rešen. In potem se tukaj govorimo o popisih sistemov in pogodbah in o SLA-jih, ki bodo morale biti polinkane na to centralno točko. Seveda zato potrebuje informacijski sistem, ticketing temu dostikrat rečemo tako preprosto, in za ta informacijski sistem bo ta enota tudi skrbela. Nazadnje, pa ne najmanj pomembno, je pa upravljanje in izvajanje baze znanja. Namreč centralna vstopna točka, zasnovana na način, kot je opisan, je pravzaprav največji vir informacij, kaj se v resnici na terenu dogaja. Vsi ostali sedimo v pisarnah, gledamo v neke ekrane, gledamo poročila, medtem ko oni vejo, koliko ljudi ima težavo s čim, ali se vzorci ponavljajo, in potem se lahko vprašajo, kako ukrepati. Včasih je ukrep ta, da naredim boljša navodila, včasih je ukrep ta, da naredim video posnetek, ker prej je tekst ni bil dovolj razumljiv, včasih je ukrep ta, da predlagam spremembo v sami storitvi ali pa v samem informacijskem sistemu, in to vse se mora reflektirati v bazi znanja. Baza znanja ne bo interne narave, ampak bodo predvideni mehanizmi, da bodo to znanje na ustrezen način dostopno javno ali pa poljavno. Seveda je baza znanja navodila za uporabo nekega ZVM-a, seveda je javno dostopna informacija, mogoče neki standardi, protokoli, pridobitve varnostnih žetonov in takih stvari, tega običajno ne daješ ravno, da javno objaviš, ampak nek onboarding protokol izvajalcev, ki bodo preverjeni z SLA in NDA in tako naprej, bo pač odprl vrata izvajalcem do nekih drugih virov informacij. Seveda, ker govorimo o digitalnem svetu, tudi ta del bo primarno v digitalni obliki. Drugi del je pa quality assurance. Čisto iskreno z kolegi pa svetovalci smo dolg časa se spraševali, torej vedeli smo, da to želimo, nismo pa čisto točno vedeli, kam to umestiti, in po več iteracijah, kje bi to bilo, dejansko vidimo, da to smiselno, da paše v ta podporni center. Ravno zato, ker gre za organizacijo, ki bo tako ali tako sodelovala z izvajalci, z regulatorji, z uporabniki, in ki ni development vrsta organizacije. Torej naj nekje razvijalci razvijajo kontaktni center, če ne drugače, on jim bo pomagal pri pravilih igre in tako naprej, ampak ko bo pa izdelek predan kot predlagan za uporabo, ga pa pač mora nekdo preveriti, in na koncu smo to umestili v ta enabling services steber organizacije. Zdaj, IT hiše, razvijalci, mislim, da vsi dobro veste, kaj quality assurance je. Za ostale pa mogoče, torej quality assurance ni enako kot preverjanje kvalitete, quality assurance je na višjem nivoju. Kvaliteta ima namreč, da jaz sploh lahko zagotavljam, da imam kvaliteto, moram vzpostaviti neka pravila igre in procese in jih izvajati. Skratka, ne si predstavljati, da bo ta organizacija tista, ki bo testirala, ki bo klikala in pisala zapisnike. Ta organizacija ni tista, ki bo pisala testne scenarije, bo pa ta organizacija tista, ki bo vedela, da obstaja nekje neka razvojna naloga, ki bo predpisala, da je za to razvojno nalogo pa potrebujemo, ne vem, testne scenarije, avtomatske, ročne, kakorkoli, pomagala projektu, da bodo lahko z nekimi obrazci, z znanjem, da bodo lahko to izvedeli, in potem seveda bodo tudi zahtevali dokazila in kot taki bodo imeli odločevalsko vlogo, soodločevalsko vlogo v projektih, kdaj je recimo neki izdelek končan in gre lahko v produkcijo. Vse to seveda za sabo potegne neke rešitve, register kvalitete v povezavi z centralno bazo znanja. Če imaš centralni organ, ki pozna več razvojev, ve, da ta problem smo imeli pa že na drugem projektu, glejte, tamle so rešitve, ki bodo tudi vam pomagale, je to smiselno, da je skupaj. Zraven so seveda poročila, soodločanje in pa splošen, ta, bom rekel, contribution k temu, da bo lahko to, kar že je zdaj zamišljeno, enotno, centralno, data fluidity, dostopnost podatkov med organizacijami, med državami, tudi resnično lahko zaživelo. Hvala lepa.
Thank you,
Hvala lepa. Vidimo, da smo v dobrih rokah. Sedaj pa za zaključek tega sklopa prisluhnimo še kratkim videosporočilom, torej deležnikov, ki so sodelovali pri pisanju strategije. Videli bomo predstavnike Združenja zdravstvenih zavodov in Gospodarske zbornice Slovenije. Pa si oglejmo.
Hvala vam za povabilo in tudi seveda ministrstvu za povabilo v delovne skupine. Sodelovalo je pri ustvarjanju te strategije veliko deležnikov, deležniki z področja zdravstva, torej zdravstveni delavci, predstavniki NIJZ-ja, predstavniki zdravstvene zavarovalnice, predstavniki ministrstva, mi iz Gospodarske zbornice kot predstavniki gospodarstva. In sodelovanje je bilo zelo zanimivo. V začetku smo pač iskali skupni jezik, ampak potem smo te prve težave prebrodili in je bilo veliko sinergije, je bilo veliko ustvarjalnosti, iskanja skupnih rešitev in iskanja, kaj je najboljše v bistvu za pacienta kot nekako centra te nove strategije. E-strategija predvsem prinaša bolj učinkovit zdravstveni sistem, ker bo pacient v centru tega in pacientovi podatki, torej združujemo vse podatke o pacientu za bolj učinkovit sam proces zdravljenja pacienta. Po drugi strani ta ogromna količina podatkov, ki se zbira, je zelo pomembna za razvoj novih metod, novih algoritmov v zdravstvu in zaradi tega bo omogočena tudi ta sekundarna raba podatkov, kar pomeni, da bodo podatki pod določenimi pogoji, upoštevajoč vsa pač etična pravila in zasebnost pacientov, bodo ti podatki na voljo za razvoj novih zdravil, novih terapij in za epidemiološko. To je nekaj novega in nekaj, kar bo naslednji korak v inovacijah v zdravstvu.
Pacienti bodo imeli na enem mestu dostop do podatkov o zdravstveni in zobozdravstveni oskrbi, dostop do e-naročanja, e-recepta, evidence cepljenja in pa preko portala bodo lahko tudi komunicirali s svojim zdravnikom. Zdravstveni delavci bodo na enem mestu dostopali do pacientovih podatkov in zdravljenj in na voljo bodo imeli bazo znanja, ki jim bo v podporo pri njihovih kliničnih odločitvah, pa seveda tudi preko portala bodo lahko komunicirali z drugimi strokovnjaki iz različnih področij. Tudi inštitucije bodo lahko dostopale do primerljivih in ažurnih podatkov, kar jim bo omogočalo lažje in hitrejše izvajanje analiz. Lahko se bodo pridobivali statistični podatki o zdravstvenem varstvu, epidemiološki statistiki in pa znanstvenih raziskavah.
Torej, komunikacija, sodelovanje in vključenost deležnikov je ta recept, ki nas bo popeljal tudi korak dalje in tudi korak hitreje do končne implementacije. Seveda pa tudi nas druženje in povezovanje v tokratnem odmoru in osvežitvi bo popeljalo potem tudi v tretji del naše konference. Sedaj pa vas vabim ponovno, da si vzamemo odmor za osvežitev in vrnemo se v dvorano za tretji del ob 11:30.
Ne vem. A ga imaš zdaj? Zdaj ga slišiš, ok. Ok, zdaj pa moraš pa oddaljeno lokacijo pa slišati. Ja, oddaljeno lokacijo Zooma pa samo tle na monitoring. A ti lahko nekaj rečeš? Sam mikrofon vžgi tvoj? Ne, na tvojega, sam da slišimo oddaljeno lokacijo.
Test.
Ja, tle moramo na zvočnik poslušati. Ja, na zvočnik.
Test.
To rešila, tole.
Ja, dej.
Ja, ne, zdaj če bo klopu letelo dvorano. Aha. Rešila, čakaj. To ga mora biti tlena. Stane tako me to zdaj tam. Čakaj, sem spore naredil.
In kaj pa, če ga pokličete?
Tegale.
Ja, tu slišim, zato ker imam mikrofon prižgan. Pomemben je, da ti govoriš, povej. Ja.
Test.
Ja, v redu je. To je to, kar rabiš. Zdaj pa ti slušalke v gol, govoriš, to ugasiš in govoriš prek mikrofona.
Test. Tako?
Ja, to je to.
Ok, pa prižgem.
Pa prižgeš svoj video. A v Švedu glas.
Hi, we are having a quick test with Mr. Jordi and Mrs. Pinto. Can you turn on the camera and the sound, please?
Hi,
Hi, how are you?
I'm good, and you?
And Mrs. Pinto? Okay, did you find the place?
Yeah.
Oh, okay. So you will be in the discussion, so you don't have any presentation. Can you speak a little bit more that we can hear the sound?
Yes. Today I will be speaking in this panel discussion. I will be sharing the stage.
Excellent.
Yeah.
So excellent. Just to remember that you have to watch in the display, not around, because it's difficult to listen you if you to the camera. Yes, you have to look at the camera.
Okay.
Okay, so that's it for my side. So we have the Slovenian language on the stage. You will be presented in the Slovenian language. When you hear that you will be announced, just turn on the camera and the sound.
Okay, I will.
There is as well interpretation. You have it at the globe down, so you can select the English channel so that you can follow the discussion in English.
Okay, cool.
Yeah. Okay,
Yeah,
good. Thank you.
You're welcome.
So now you can turn off the camera and the sound. Thank you. We are waiting for Mrs. Pinto. Yeah. Maybe we wait 4 minutes because we said at 11:15. Test, test. Test, test.
Cenjene dame, cenjeni gospodje, dobrodošli v tretjem delu današnje konference, v katerem se bomo seveda osredotočali na digitalno preobrazbo zdravja izkušnje evropskih držav. Ker je Slovenija v sklopu priprave strategije obiskala tuje vodilne države na področju digitalizacije zdravstva, bomo v okviru panela, ki sledi, skušali prikazati, s kakšnimi izzivi se srečujejo tuje države pri implementaciji svojih strategij digitalizacije zdravstva. Z nami bodo predstavniki Portugalske, španske regije Katalonija in Estonije. Panelno razpravo bo povezovala gospa Alenka Kolar, vršilka dolžnosti generalnega direktorja Direktorata za digitalizacijo v zdravstvu, Ministrstvo za zdravje, in predstavila tudi vse sodelujoče paneliste, ki bodo z nami tako v živo, kakor preko spleta. Gospa Kolar, izvolite.
A je, ok. Zdaj pa imela. Hvala za besedo. Tako kot so me napovedali, jaz imam enega kolega tukaj, gospoda Tonisa Jagusa, tako da kar prosim, da se mi please join me. Prihaja iz Estonije in pa dva sodelavca, kolega, tako gospod Katjo Suaza Pinto. Kako jo bomo dobili na zaslon? Portugalske. Waiting. Ja, ne. In pa, zdaj upam, da se izgovori Jordi Piera Jamines z Katalonije, ki bo se nam tudi pridružil online. Jaz bi prosila, če lahko nas povežete. Tudi po 2 letih COVID-a nam to še ne gre dobro. Oh, here you are. Again, did you hear me, Katja and Jordi? Do you hear us?
Yes, good morning.
Good morning, good morning.
Yes.
Is it Jordi or how do you pronounce it?
Jordi is okay.
Jordi, it's okay. Thank you. I would ask the questions for my colleagues, my visitors, my staff, the people who are here with me in English, so it will go a little bit faster. But when they answer in English, you will be translated, so we will have some time in between. Okay? Mm-hmm. So my first, maybe here for physical presence, thank you. Please, for each of you, shortly introduce yourself and what you do, where you're doing it.
Yeah. I work in Estonia in Health and Welfare Information Systems Center, and I'm here as a head of health division. What do? We develop and maintain Estonian National Health Information System, and actually most other health-related registries in Estonia, for example, registry for medicines, registry for medical personnel, registry for non-communicable diseases, and so on and so on. So.
Thank you. Katja?
Hello, good morning. My name is Katja Pinto. I am an MD and I have the role now as the head of International Affairs and Global Digital Health at the Shared Services in Ministry of Health in Portugal. And we are the National e-Health Authority, and we are also responsible for the development and management of health information systems for the Portuguese National Health Service. It's a pleasure to be here with you again.
Thank you, Katja. And now please, for the last one, but not the least, Jordi.
Hello, everyone, and thank you also for having me here. I'm Jordi Piera. I am my background is in computing science and engineering, and also in economics. I'm also a PhD in health economics, and I am currently the director of the digital health strategy of the Catalan Health Service, which is the unique insurance here in Catalonia. And while we are in charge, it's my position is very similar to the one from our colleague from Estonia. I'm in charge of all the digital health platform and all the longitudinal technologies that we are providing to our health provider organizations and also to our citizenship. And well, currently implementing quite a comprehensive and challenging digital health strategy for all the region.
Thank you to all three of you, and I think you got the preliminary questions that we will ask, or I will ask you. Maybe, of course, during the round table, everything can happen and some new question can arise, and of course, the public is also invited to ask some question. But I would start with, here again with Tonis, and maybe go in the same direction as the first round. Then we will see how the talk will go. My first question would be, what has been the obstacles and mistakes that you made when implementing e-health in Estonia and we can now avoid?
When before you mentioned that Estonians are good salesmen, then now I can also tell you what salesmen won't tell you. We launched our health information system in 2008, but planning of the system started years earlier, and there was a vision. We can say that this was what we had before the strategy, and we acted with that. Then in 2015, an e-health strategy was formed and adopted by the government. A few years later, apparently we saw that the e-health itself, or the e-health strategy itself, it actually didn't work. Somehow it happened that the health area itself and the e-health didn't align all the time. So there was a decision made that e-health strategy should be written into National Health Development Plan. And we can say that, yes, it was done, but actually a lot of, not all of it, not all the points. And now, a few years later, we are in the phase where we have adopted, or we are implementing an e-health governance structure, which is now based on the previous e-health strategy. But now, when I'm going to talk about that, what did we lack with e-health strategy? There were two things. One was continuous financing. We all know what it means, that there is never not enough money, but there is a strategy, there is an action plan, there are goals, then there should also be supportive background systems and actions. And actually we missed that. So we got most of our money from EU funds, maximum 500,000 euros each time. And when there was, for example, the second phase of the project, we had to make another application, and it took time. So, for example, from funding application to actual start of development, it took minimum 6 months. And at the same time, we have our development partners, our partners team, our own project managers and so on. And of course, they didn't stand still. We found for them another interesting projects, but in some cases, our development partners had to find another projects, and we didn't get them back. And second thing, more important, is that it lacked on the background governance model, a transparent governance model. It starts from the new ideas. How are the new ideas evaluated? That what should go into development until the transparency of the product portfolio and reprioritizing of the projects. So basically two main things.
Thank you. Katja, can you make familiar yourself with that? Were the same errors or mistakes and obstacles found when developing it for Portugal?
Yes, I agree that there are many common challenges among all the countries when implementing a digital health strategy. We in Portugal decided to create more than 10 years from now a national e-health agency that was intended to deal with digital health as a health service in its own right. So we were entitled with the objective of having a centralized vision for the health information ecosystem in the Portuguese NHS. And having these clear and defined goals and objectives really supported Portugal in evolving in its national health strategy and actually the development of the strategy itself, the national strategy for the e-health information ecosystem that actually sets out the objectives and roadmaps for digital health development in Portugal. That was a major breakthrough in the country that allowed Portugal to move faster forward towards integrating digital health into the national landscape. Other challenges that we faced during the process was the alignment between digital health, the digital health strategy, and the national health plan. And so we overcome that by ensuring that we involved stakeholders, all national stakeholders, in the development of the national strategy for e-health. And that was also very important to make sure that technology was being used to provide and to advance quality of care and public health interventions. We did that by identifying with stakeholders also how to better provide training and support for healthcare providers to have them on board. And at the same time, we were able to hire skilled technology staff that allowed us to have secure and compliant technology purchased, especially compliant with the relevant regulations. That was also a major challenge for us at the beginning, but the funding scheme for digital health in Portugal and the very nature of our agency, we are a public enterprise, allows us to have a lot of flexibility in dealing with staff and technology procurement. One of our major concerns since the beginning was towards interoperability and standardization. We wanted to make sure that we had a future-proof health information ecosystem that would allow us to make health information systems more and more connected, anticipating the developments in big data and AI. So we were deeply involved in cross-border initiatives at the EU level, but also at the international level, with governmental and non-governmental agencies dealing with standards for data and communication protocols to make sure that we selected the adequate tools so that our systems would be able to evolve with the evolution of technology and the need of healthcare providers to connect to each other. So in a nutshell, I can say that these were our main challenges, and we totally agree that we should collaborate also at the EU level to make sure, and this is one of such initiatives, to make sure that we have alignment in plans and that we can really learn from each other.
Thank you, Katja. And Jordi, how about Catalonia? How was with you? Your obstacles, your errors.
Well, besides from agreeing with the comments of my two colleagues here, and also maybe building a bit on the comments from Katja when she was talking about the strategic alignment in between the health plan or the strategic plan for healthcare that all of us which is the the business plan, so to say, or a strategic business plan, and the strategic alignment with the digital health objectives, that's a tricky one. That's a tricky one because it's difficult to perform change in healthcare. We all know that. I mean, it takes time to perform such a change in healthcare. When setting the strategic objectives in our plan and the execution plans in order to implement the digital health strategy, I think that one of the major things that we need to take into account is to do not set these objectives with a marketing or a political time frame, but because this may lead us to being a bit over-optimistic, and that was our situation. We all know that in general, politicians have, well, a short-term view, which links to the time that they will be holding power, and obviously they want and they need results within that period of time. But in order to perform such a change in healthcare, we need time, and well, this time may overcome the time certain politicians will be here. And I think that when setting these objectives, we need an agreement, country-level agreement in between all parties, that this should transcend somehow the political time frame. For us, that was one of the biggest mistakes that we made. In our first planning, we were very over-optimistic when setting the objectives, and it was due to the pressures of politics, and that, well, I recommend you to look into that and to acknowledge that change is difficult in healthcare. The second one for me is that we never pay, I would say, enough attention in communication, in this internal communication that will allow us to, I would say, to manage expectations within all the ecosystem. And here I'm talking about healthcare professionals, I'm talking about healthcare provider organizations, I'm talking about politicians. I mean, we need to communicate very well the advancements of the plan and the achievement of the different objectives that have been set around the plan. And many times we also oversee the importance of this part of communication. So for me, it's these two things: being very careful when setting the objectives, acknowledging that healthcare practice is difficult to change, and also not overlooking the communication part, and obviously agreeing with all the comments from my two colleagues previously.
Thank you to all three of you, but I note down some comments, and there are two pillars of troubles, as I can rephrase. One are financing, and the other one, as Katja mentioned in one sentence, we were able to hire. This is the staff. So how do you cope with lack of IT staff? But let's start this time with Katja.
Yes, that's a major concern. Of course, we are still dealing with that challenge now, and I believe that it's common to all of us here in the panel and for sure in the audience. We, as I told you, the National eHealth Authority was created as a public enterprise. So we have a special regulation that it's a little bit different from the traditional governmental agencies that allows us to have more flexibility in hiring additional staff and also in outsourcing some of the tasks of the digitalization work to specialized companies that have experience in the field. Because of course, governments and governmental agencies know that there are very specialized technical areas where we will not have the adequate staff in-house. We will need to outsource some of the tasks. On the other hand, for some tasks, we should have the adequate staff in-house, and we should have the flexibility to find it in the market and to hire additional staff as necessary with the adequate experience to support the digitalization of healthcare. So these two requisites our regulation, or the regulation that determines the functioning of the National E-Health Agency, alongside with our strategy regarding staff and outsourcing, but also automation. One of our key objectives is also to implement automation tools to processes to reduce the need for human intervention, and that is something that we also aim to do and look when implementing and developing new systems in order to reduce the need for additional staff. And of course, collaboration. One additional way to make sure that we have additional expertise in-house is to collaborate with different community partnerships, either universities, but also other community organizations that can support us in specific projects, and so allow us to have additional hands to develop the projects that we need to do, and at the same time additional expertise. So the combination of these three things, the financing scheme of the National E-Health Agency, the ability to outsource, and the collaboration with different community universities and organizations are actually the three pillars that we rely on to make sure we have the adequate staff to the development of the projects here in Portugal.
Thank you. Tonis, can you relate to that? You are also from TEHIC. This is special agency or public company, or how is it?
It's, let's say it's agency, but we are under the Ministry of Social Affairs. But our approach is that we outsource basically most of the development work. Who do we have? We have project managers, we have service managers, we have testers, we have IT architects, and so on. So we don't compete with private companies for developers. That's our, let's say, that's our strategy, because we cannot be successful in every area. Each time when I see the news that there's another international company opening an IT development center in Estonia, I understand that, okay, now the competition for workforce is again harder because they hire also project managers and so on. And we don't want to do it for developers. But yeah, luckily, because of economic situation, there are also now news about layoffs. And those people are, I think, are quite quickly again hired, either by the government or other companies. So that's our point of view. And also we collaborate with other organizations and, for example, with universities, because we cannot do everything on our own. So, for example, with Tallinn Technical University, we have several projects with their e-health faculty, so that we also kind of outsource it to the academic institutions.
Thank you. And in Catalonia, you have enough staff?
I would say yes, we have. I mean, the ecosystem is quite wealthy in terms of human resources, and when it comes to IT staff, the situation for us is very close to the one that our colleague from Estonia has just described. So we do not compete with private companies or industry partners to get developers. We cannot compete with them in salaries. You know that in the public sector, the salaries that we pay are quite lower. What we have in the public sector is service designers, is project managers, people helping us, architects and blah, 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 helping us to design our model of service, and then controlling all these companies to whom we subcontract the different developing services that we are aiming for. Now, I would say that what we are struggling the most is with the upscaling or upskilling also of the capabilities of our healthcare professionals that necessarily need to be involved within all our digital health projects. And that's a tricky one because what we have seen is that in the way that healthcare professionals, especially medical doctors, have been trained has truly not changed for many, many years. And they remain being taught in the same way maybe that they were taught 50 years ago. So here we are working a lot with universities, and we have developed a lot of postgraduate programs, but obviously this is not the formal and mandatory training, and this is something that will solve for us the lack of this type of staff in the future, right? Because changing the university and the formal programs, it takes a while. In the meantime, we are trying to solve the current needs that we have. Obviously, to everyone that we hire, we are providing training on IT capabilities. So to say, it's either standards, terminologies, semantics, whatever it is, we provide this training. But we are trying to copy the model of the NHS in the UK and the NHS Digital Academy, in which they systematically train healthcare leaders on digital skills by building in the principle that if we need to perform a transformation of the healthcare sector towards digital, our leaders need to have or to know about these capabilities. And the truth is that I would say that same as everywhere else, our healthcare leaders do not have these capabilities. We think that the approach that the NHS took by training these cohorts of professionals, healthcare professionals, in digital capabilities is a good approach. And we are trying to copy paste the same strategy. Basically, we have not yet been successful, but we have now taking advantage of the financing that is coming from the resilience funds. We are trying to set up a similar structure, trying to give the skills to these leaders in order to perform the change.
Thank you. You mentioned you are financing the education of the future leaders, but how is with the financing and of maintenance of IT, user solutions, hardware, software? Where do you get the maintenance financing, not the investment part? Mm-hmm. Every year maintenance, or if you hire some solutions. I mean, you don't own them.
In Catalonia, we have a strategy basically of owning the solutions. It's true that we normally do our own development, and this has been like this for our primary care record, for the remote consultations. Many of these platforms we grow and maintain them, and from the design to the maintenance of them. It's true that that in the current times that we are going through, and with all this money flowing around Europe from the resilience funds, there's a lot of money for investment. And then the question is whether we will be able to sustain these services or these new services that we are putting here over time. What we are doing is our strategy is replacement of the legacy system. So basically all the investments that we are conducting right now go in line with the reduction or the amortization of the current legacy systems and moving towards new health information technologies. And we think, and that's what we are working on all the business cases that will ensure the sustainability over time with the current maintenances that we have right now. We know that this is always not possible, and possibly we will have to maintain two infrastructures for a certain period of time. But the idea is to reduce technical debt, to reduce the costs of all these old-fashioned legacy systems, because we are starting to have a problem of obsolescence. You must think that we started here developing digital health technologies maybe 30 years ago. These technologies are reaching a point in which, we cannot patch them anymore. And now we are in this process of truly renewing all these foundations of our healthcare IT infrastructure. It's a process, obviously, that is a challenging one. There are very big tenders going on, even with the participation of some Slovenian companies. You may think that there in Slovenia, I have heard back in the day that you are lagging behind, but the truth is that you have companies that are very advanced, such as Better. And well, these guys are part of some of our big tenders that are going on in here. But my message with this is we are replacing a lot of the current legacy systems that are costing us a lot to maintain. And the business case is to substitute them for new technologies and to maintain the same levels of maintenance that we currently have.
Tonis, can you add something to that financing part of maintenance?
There is always money missing. When I mentioned before that, for example, if we get money from structural funds from EU, then it means that maintenance money must come from the state budget. Now, after COVID, I thought that now finally politicians and decision makers understand why IT is important in healthcare. But apparently, I think that pain was not yet deep enough, because now, let's say, we are not advanced. We have not moved on from that point very, very far. So basically, I think we all have the same problems. Always, we can find money for investments, but yes, to keep the systems up and running, to pay personnel and so on, this is always the hard part.
Thank you. We have the same problem here. But now from those two, let's say problems or challenges, is go to what we are here for. We are here for our patients. How, Katja, did you manage to include patients that are not digitally very advanced? How do you do that?
We created some years ago what we call SPMS Academy. So we have a specific department that it's intended to provide education and training opportunities for citizens and patients, and also healthcare staff, to increase their digital literacy. So this includes courses on how to use digital health tools and applications, information on how to access digital health services. This is very useful. We partner with patients' associations to develop these online courses, and they actually are physical and online, but they are more and more online, and we were able to reach citizens through very different patient associations and community services, and that it's something that it's very useful. We also have been investing in awareness campaigns. We have wide campaigns in regular communication media, TV, newspapers, for citizens to inform them on how they can use our NHS 24, which is the door to the National Health Service, and the portal and the national app. These awareness campaigns were very beneficial to capitalize on the boost that COVID-19 brought to digital health tools used by citizens, and to use this to increase also the use of other digital health tools that we have available for citizens. Another approach is to have a tailored approach for different groups. For example, older adults, low-income communities, and rural areas. We have what we call NHS 24 counters. These are physical counters that we partner with local health administration, municipalities, to have physical counters where older adults or people with disabilities or that are less digitally skilled for any reason can have support from local health administration technicians on how to use digital health tools. So they can physically go to a counter and they will be taught there how to use the national portal, the national app, supporting installing the app in their cell phone. And so this is proving to be very, very useful to reach out vulnerable communities and to make sure that we include everyone when developing digital health services. So these three pillars, education and training, awareness campaigns, and tailored approach with physical counters for hard to reach population or less skilled population is really supporting us to make sure that we have digital services available for everyone in the country.
Jordi, on your part of Iberian Peninsula.
I think we have a similar strategy, such as the one that our colleagues in Portugal have. We have been able, in Catalonia, we have, and also in all the rest of Spain, primary care is fully integrated within the healthcare sector. It does not rely on the municipalities, and general practitioners do not practice in a private practice, but they are in primary care centers. We use the primary care centers as the main access door to our healthcare system, and GPs effectively act as the gatekeepers to the system. In primary care centers, we've been able to set up similar structures, such as the one that Katia was mentioning for training the people with less digital skills or less digital literacy. We have also some computers and small offices in which patients can go and do certain care processes, I would say, that can be done remotely throughout these counters and throughout these clinical workstations in the primary care center. And this helps us to solve partly the problem of the people that has access problems due to socioeconomic constraints. We are truly very worried about the access to healthcare, and we have recently, it's not yet published in the scientific literature. We are working on the article, but we have been able to find differences in population when accessing digital health services, depending on their socioeconomic status. And we have proven this right now. We have proven this in 2 or 3 different ways. And we are going to publish this, even though it's a result that goes against our healthcare system. But it's also to raise awareness about the importance of really when rethinking or when digitizing the healthcare pathways, so to say, to think about these people that due to socioeconomic problems or also to digital health literacy problems are not able to access our services. And for those, I would say that when we are thinking the healthcare processes, what we are doing is also bearing in mind to maintain the face-to-face channel for these people that won't be able to
had their own e-personal card already in 97. That is 25 years ago. Is the situation different in Estonia? You are digitalizing your population 25 years.
We started with digital literacy actually in the end of the 90s with a project called Tiger Leap, where we connected schools to the internet and created computer classes there. So the target group were very young people, and I was part of the target group back then. Then there was a project called, I think it was called Open World. And it meant that we created public internet points. They are still there, mostly in libraries. And now I'm going to give a good example what happens when we say digital first. You all have heard this kind of sentence. And we, we managed to create the COVID certificate service that fast that the real world didn't follow up. So that when we launched the service in June it was last year, yes, then it was possible to get this COVID certificate through the patient portal. The patient goes, has a vaccination, the data is sent to the health information system, and as soon as the data is there, it was possible to log in and download the certificate. But what was missing was exactly this part of population who doesn't have access to there. So basically, we were the only organization who was able to issue these, but we are an IT organization. So we adopted. Finally, for 1.5 months, I think, 1.5 months, a lot of my colleagues issued COVID passports, COVID certificates, from help desk workers even to our CFO. So we were suddenly we were not an IT company, we served customers. So there was a line behind our door. So let's say, I'm not blaming us for that we moved in such a fast pace, but then our colleagues from the ministry and from the Social Security Board managed to get the system working so that these certificates were issued in 20 different offices in Estonia. And also we advertised that the library is the place where you can go, and then the librarian will show and help show how to log into the patient portal and help how to get it. So it was interesting 6 weeks last summer.
Thank you. For my last question, for all the three of you, maybe starting this time with Jordi, our time is running out, as I can see here on my monitor, is where do you see your e-health in 5 years? What will you do? What do you think will happen in the next 5 years?
Well, that's a tricky one. I hope that a lot of things will happen. We are currently undergoing, as I was mentioning before, a major transformation of the foundations of our health information systems infrastructure. We are trying to rip off all the legacy systems and to build what we call a new infrastructure. So we are basically rebuilding our health information technologies around data and health information. And for this, we are working to have common semantics to represent clinical knowledge, because we have seen that it's taking us too much effort to systematically use this data. And for each data science project, for each time that we need to perform any new interoperability integration, is costing us a lot of effort. We know a lot about interoperability and integration, and we have successfully merged all the Catalonian healthcare providers into a unique electronic health record many years ago. But this is costing us a lot. So in 5 years, I hope that we will have been able to deploy all these ideas that we have, and the main one is building this new electronic health record with a longitudinal view. And with a longitudinal view, I'm talking about an electronic health record that will overcome the barriers of the healthcare levels, also the barriers of the different healthcare provider organizations. And we will have a system in which multidisciplinary teams of healthcare professionals are able to deal with the health condition of a specific individual smoothly. Right now, we have a patchy situation, which more or less solves the challenge, but it's time to acknowledge that we can do this better, and that after 30 years of digitalization, there's other ways to do this. So we are quite involved in a crazy journey for some people. They think that what we are doing is it's a bit mad. So I hope that we will have survived to the process, and that in 5 years we can well, refresh this conversation with you and let you know about how this has advanced and whether we have been successful or not.
I hope we can tell you that we were successful too. Katja, how about you?
Yes, I think we all hope that. At the moment, we have also a comprehensive plan coming from Recovery and Resilience Funds to address and progress in several of the challenges of the digital transformation. We have four main axes: having a robust infrastructure, so renewing our infrastructure capabilities, putting data to work, either for healthcare professionals, but also for patients, and renewing and improving the digital clinical pathways for having a truly digital care for health professionals. So I hope that 5 years from now, in the first place, that telemedicine will be much more implemented than it is today. We need to make sure that we can reap out the benefits that were developed in the later years and have improved telehealth services for our citizens, and at the same time that we are more able to have interoperable systems that can connect electronic health records, laboratory data, medical images, so that we have a national data lake that will be fit for purpose to have AI plugins and all other needed clinical decision supports that we anticipate that will be needed in the near future. So I also hope, as Jordi, that 5 years from now, although it's a short time, but as technology moves much faster than our psychological time, I hope that 5 years from now we will be here and successfully talking about how we were able to overcome all these challenges and how we evolved regarding digital health. We are also very concerned and regarding the European health data space. So we need to remember that we are all discussing at the moment a regulation that may be able to change the future and the landscape of our digital health cooperation. So that is something that we are also taking into account, and I think it will be a major breakthrough, and then we will for sure discuss that if we'll meet 5 years from now.
I hope we meet physically in 5 years from now for all three of us, four of us. And now, as we started with my colleague here beside me, I would end with the same question. How about Estonia e-health? Where will you be?
I also hope that in 5 years we don't have our legacy system anymore, because we are currently developing the next generation health information system. And with that, I also hope that after 5 years, we have less different registries, like quality registry, for example, cancer registry, tuberculosis registry, and so on, because actually this data should be in the health information system, and this for the registry, there just be a kind of view for the interested persons. Then what else? I'm sure that in 5 years we will use a lot genome information in clinical work, because this is something what we are currently working on, and we want to launch this service in the beginning of next year already. Of course, it will take some time to take off, but still. And then I believe in the pan-European collaboration, because with Finland we started 4 years ago exchanging electronic prescriptions. Now we exchange patient summaries, and there will be more and more services. And one more thing, we didn't mention in this panel cybersecurity. So I hope that we will all take it very seriously. We all the users here in this hall. Because, you know, we can use firewalls, encryption, we can use blockchain for avoiding data manipulation and to use whatever technologies. But in the end, there is one user behind the computer screen who clicks on the suspicious link, and then bad things start to happen. So let's remember that and hope that after 5 years we can say that the health data is still secure.
I think we all hope that. We are over our times, but I would still, can I ask an audience if there is a question for any of our panelists before we finish? Do you have any question? Typically Slovene, so no questions. To all the three of you, thank you very much. It was an interesting discussion, although too short, and hopefully next time we can really see you all in Slovenia, or maybe in some of your country. Thank you.
Sure. Thank you. It was a pleasure. Thank you.
Thank you. Bye-bye.
Thank you very much. Hvala lepa za vse prispevke. Le skupaj smo lahko boljši in se učimo, se zgledujemo po dobrih praksah drug drugega. In če so te izkušnje tudi mednarodne, pridobimo še toliko na hitrosti in širini. Sedaj pa zadnjih nekaj minut tudi namenimo zaključnim mislim. Te pa bo podala seveda Emilija Stojmenova Duh, ministrica pristojna za digitalno preobrazbo Republike Slovenije. Oder je vaš.
Najlepša hvala. Spoštovani kolegi, cenjene dame in gospodje, dear participants for the European Commission, dear colleagues from Catalonia, Portugal, Estonia. Je res čas, da sem tukaj danes z vami. Se iskreno zahvaljujem ministru in njegovi ekipi, da so mi dali zadnjo besedo. To pomeni, da sem lahko ostala in poslušala to konferenco do konca. Vesela sem ne samo kot ministrica za digitalno preobrazbo, ampak tudi kot Emilija. Kot nekdo, ki hodi k zdravniku, ki se sooča z težavami, s katerimi se soočajo naše prebivalke in prebivalci, in nekdo, ki si želi urejeno stanje na tem področju. Digitalizacija je področje, ki je za marsikoga nerazumljivo, je abstraktno, veliko govorimo o tem. Zakaj? Tudi marsikdo misli, da je nepotrebno, saj ne vidi dodane vrednosti oziroma koristi zase. Vidimo prednost v nekatero področje, ko vidimo osebne koristi. Zato na naši službi za digitalno preobrazbo, ki bo kmalu postalo tudi ministrstvo, izvajamo številne aktivnosti, različne projekte ozaveščanja, iniciative, sestanke, se redno srečujemo z različnimi deležniki, kjer jim razlagamo, kaj pomeni digitalizacija, kako jim lahko pomaga, kako lahko prispeva k znižanju stroškov, k bolj učinkovitemu delovanju in tako naprej. Pa kot sem danes že povedala na novinarski konferenci, imamo res veliko srečo, da v primeru Ministrstva za zdravje tega problema nismo imeli. Kot ste tudi sami imeli priložnost danes videti, tako minister kot njegovi kolegi, vršilka dolžnosti direktorice, gospa Kolar je večkrat to jasno pokazala, da ne samo, da se zelo dobro zavedajo, kaj pomeni digitalizacija, ampak tudi dobro poznajo težave, izzivi, ki so noter in vejo, kaj morajo pač opraviti. Torej, vedo, da učinkovita prenova celotnega zdravstvenega sistema, čeprav smo se danes pogovarjali samo o digitalizaciji v zdravstvu, ampak učinkovita prenova zdravstvenega sistema preprosto ni mogoča brez izpeljane digitalne preobrazbe. V uvodnem nagovoru, tudi na tiskovni konferenci in tudi kasneje dr. Kolar, minister, je jasno predstavil ključne prednosti digitalizacije. In to so transparentnost in sledljivost. Hvala lepa, ker ste nas opozorili tudi na to, da smo pozabili. Ampak transparentnost in sledljivost so možni zgolj takrat, ko imamo kvalitetne podatke. Ko te podatke imamo zbrane in tudi, ko jih potem lahko ustrezno analiziramo. Konec lanskega leta smo na službi vlade za digitalno preobrazbo v sodelovanju z OECD začeli z izvedbo projekta Skrbniki podatkov oziroma Data Stewards, kjer želimo usposobiti v javni upravi tako imenovane skrbnike podatkov, ki bodo razumeli, kaj pomenijo podatke, zakaj jih je potrebno deliti, na kakšen način, kako je potrebno poskrbeti tudi za varnost teh podatkov in želimo si, da ti skrbniki podatkov naprej potem usposobijo še njihove kolege. Veliko smo se ukvarjali tudi z informacijskimi sistemi. Danes je bilo večkrat predstavljeno strani različnih strokovnjakov, strani predstavnikov ministrstva,
Dostikrat so bili sistemi načrtovani na način, da so pač pokrili zelo ozko, točno določeno področje znotraj ene organizacije. Zaradi tega potem ti informacijski sistemi se niso razumeli, niti znotraj iste organizacije, niti znotraj enega področja, kaj šele to, kar si mi želimo. Se pravi, dobro spomnim našega prvega sestanka, ko sem dr. Kolarjevi predstavljala naše vizije, kako bomo mi imeli vse skupaj povezano, pa me je hitro mi je predstavila realno stanje, kakšni so, izzivi so daleč od tega. Zato smo naredili pregled. V zadnjih nekaj mesecih smo analizirali, kaj sploh imamo v Sloveniji. Ne samo v zdravstvu, ampak v celotni javni upravi. Tako da stanje zdaj dobro poznamo. Pogledali smo si tudi primere najboljših praks. Estonijo smo obiskali tako minister za zdravje za svojo ekipo, bila sem tudi jaz svojo ekipo. Smo pogledali, na kakšen način rešujejo pač izzive. Tudi danes je bilo marsikaj predstavljeno s strani drugih držav članic. Zanimalo nas je, kaj lahko združimo, in takoj smo ugotovili, recimo, da lahko združimo e-osebno, torej elektronsko izkaznico in zdravstveno izkaznico, in to bo kmalu tudi na voljo. Ali to pomeni, da bomo lahko združevali vse? Pogostokrat je vprašanje, ali bomo imeli en informacijski sistem. Ne, ne bomo imeli en informacijski sistem. Ali bomo imeli eno bazo podatkov? Ne, ne bomo imeli eno bazo podatkov. Pomembno pa je, da se ti sistemi in da se ti podatki razumejo med seboj. Ne glede na to, kje so shranjeni. Za uporabnika, za nas je pomembno, da se podatek vnese samo enkrat, ampak da lahko potem različne organizacije, ki seveda imajo podlage, ki so določene v zakonih, da lahko dostopajo do teh podatkov. Danes na tiskovni konferenci je bilo postavljeno odlično vprašanje, ampak vse to je abstraktno, kaj to pomeni konkretno za uporabnike. Če naštejem samo par, ker že zamujamo, recimo, takoj smo rekli, da bomo imeli eno kartico, ki bo osebna izkaznica, jo bomo lahko uporabljali za upravne storitve in bo tudi zdravstvena izkaznica, torej jo bomo lahko uporabljali, ko gremo k zdravniku. Ne glede na to, kje bomo opravljali preiskave, recimo sama prihajam iz Maribora, ampak pogosto moram iti k zdravniku tudi v Ljubljani. Ne glede na to, če bom opravila rentgen v Mariboru, ko bom šla k zdravniku v Ljubljani, bo ta imel dostop do mojih preiskav, brez da bi mogla zaradi tega nesti posebni CD k njim, zaradi tega, ker CD-jev naši računalniki niti več nimajo prostora, kam bi jih dali. Potem moja zdravstvena zgodovina bo na voljo v e-zdravstvenem kartonu. Lažje zdravljenje, enostavnejše posvete za zdravnikom na daljavo. To je bilo tudi predstavljeno še v ostalih državah pri tem, kaj si želijo v naslednjih let. Želimo si, tukaj spet pridemo do naše Ministrstvo za digitalno preobrazbo, da v prihodnje, da bo umetna inteligenca nam na podlagi naših zdravstvenih podatkov znala napovedati potencialne grožnje in nas bo znala pravočasno napotiti na kakšne dodatne preventivne preglede. Gospa Natalie Berger in tudi kasneje gospod Jagos iz Estonije so poudarili tudi ta mednarodni aspekt. Recimo imamo že delujočo storitev, to je recept. Ne glede na to, da bomo dobili recept recimo doma, ga lahko izkoristimo v sosednjo državo ali v kakšno drugo državo, kjer bomo. In teh storitev je veliko več. Tukaj bi samo poudarila, pogostokrat prihaja do zmote, da bodo podatki shranjeni na eni kartici in potem bodo različne organizacije, različne osebe imele dostop do naših podatkov. Temu ni tako. Podatki ne bodo shranjeni na izkaznici. Za izkaznico se mi samo identificiramo. Ti podatki bodo shranjeni v različnih bazah in potem ponovno na podlagi pristojnosti, ki so določene v zakonu, tiste organizacije, tiste osebe, ki potrebujejo določene podatke, seveda bodo prišli tudi do podatke, ki so nujno potrebni. Cilj naše vlade, to smo večkrat poudarili, je digitalna preobrazba, ki namesto tehnologije postavlja v ospredje človeka. In ko govorimo o človeka, imamo v mislih tako zdravnike, tako zdravstveno osebje, kot tudi pacienta. Zdravnikom želimo omogočiti lažje delo, boljšo, pa ne samo zdravnikom, ampak tudi medicinskim osebjem, Želimo razbremeniti administrativnih nalog in želimo pomagati pri organizaciji dela k celostni obravnavi pacientov. Pri pacientih pa za nas je ključno, da na uporabniku prijazen način poskrbimo za večjo informiranost pacientov in tudi, da imajo boljšo, večjo kontrolo nad svojimi zdravstvenimi podatki. Drugi cilj naše vlade, ki ga poudarjamo vedno, je tudi digitalna vključenost. Ravno na področju, kot je zdravje, je digitalna vključenost ključnega pomena. Tukaj si res želimo na našem ministrstvu, da je vsak po eni strani, da ima dostop do tudi širokopasovnega interneta, saj potem brez tega se ne moremo pogovarjati o digitalizaciji, pa seveda tudi digitalna znanja in spretnosti. In ne nazadnje potrebujemo nujno zaupanje. In to bomo nasegli na način, da bomo lahko delovali odprto. Nam je bil zelo všeč primer iz Estonije, kjer lahko z elektronsko izkaznico lahko vsak prebivalec oziroma prebivalka lahko ima vpogled v tem, kdo kdaj je dostopal do njihove osebne podatke. In na takšen način, če ugotovimo, da nekdo ni imel pooblastila za dostop do teh podatkov, lahko tudi ukrepamo. Tako bomo dosegli tudi zaupanje. Cilji, ki sem jih naštela, so vključeni tako v strategiji za digitalizacijo zdravstva, ki so jo pripravili na Ministrstvu za zdravje, kot tudi v naši krovni strategiji Digitalna Slovenija, ki smo jo ravno v tem tednu, v začetku tedna, dali v javno obravnavo. V naši strategiji damo poudarek na horizontalnih načel, obstajajo pa potem še različne strategije, ki obravnavajo svoja področja. Minister je danes na začetku govoril o zgodovinskih priložnostih, pa bom tudi jaz. Tudi mi imamo zdaj končno priložnost, da pokažemo, kako uporabno orodje je digitalizacija, in to priložnost bomo seveda izkoristili na področju, ki je za našo vlado prioritetno, in to je področje zdravstva. Sem si delala zapiske med tem, ko ste govorili, da lahko zaključim potem. In gospa Kolar je povedala, da pri digitalizaciji tehnologija ni problematična. Res je. Zaradi tega, ker digitalna preobrazba ni tehnološka preobrazba. Digitalna preobrazba je družbena preobrazba, kjer se bomo pa seveda morali dogovoriti, ali smo pripravljeni na spremembe, ki pa niso nujno všečne, ne vedno. So pa potrebne. Danes je bilo večkrat omenjeno tudi na koncu na panelu, da so največji izziv finančna sredstva, in čeprav nisem sodnica, izkoriščam priložnost za odklonilno mnenje. Največji izziv, po mojem mnenju, smo družba v celoti. Ko bomo mi dosegli konsenz in zbrali pogum za odločitev, da gremo v reformo, takrat bomo našli tudi finančna sredstva. Evropska komisija je danes večkrat povedala tudi, da so nam pripravljeni pri tem pomagati. Jaz mislim, da ta pogum imamo in da je čas, da se tudi odločimo. Hvala lepa in uspešno tudi naprej.
Najlepša hvala, spoštovana ministrica, in seveda tudi vam, vsem ključnim deležnikom v tem procesu, želim veliko mero agilnosti, pripravljenosti na spremembe in tudi na bolj učinkovit zdravstveni sistem za jutri in tudi za prihodnost, za prihodnje generacije. Najlepša hvala Evropski komisiji za podporo tej konferenci. Hvala lepa Ministrstvu za zdravje in njihovi organizacijski ekipi, ki je odlično izpeljala pripravo in izvedbo tega dogodka. Zahvala tudi v mojem imenu, si štejem veliko čast biti v taki družbi danes. Vam pa želim lep preostanek dneva še naprej z mislijo na boljši zdravstveni sistem. Hvala lepa in nasvidenje.